morning.
Good morning. How are you?
Good. How are you?
Good. Good morning.
Testing. Looks like that's good. Okay. Everything looks good. Good morning. Good morning. Good morning. All right. So you guys had chapter 4 between last class and today. Does anybody have any questions on what you read in chapter 4? It's a brief review of the body systems. You guys all learned that in 5th grade. You probably don't remember it, but you did learn it in 5th grade. Just that our body is made up of various body systems. Each one of them has a job. So I kind of think of it like a community, right? So I have a job in the community and other people have other jobs in the community. And together, they all work together to make a community. Like, I don't deliver mail. It's an important job. I don't do it. But somebody else has to. Now, if we didn't have somebody delivering the mail, we would be in trouble, right? Somebody else has to pick up the trash. Now, I don't do that. But if nobody does it, we're not going to work together as a community because trash would be everywhere, right? Does that make sense? So everybody has a job to do. Their job is important, but alone, that job alone isn't going to get us very far collectively. So that's how I look at the body. Each body system has its own job to do. Now, if that system doesn't do its job, it's going to affect everybody else. Okay, make sense? We'll get into that in a little more detail in just a few minutes. But let me go ahead and get your scores for chapter 4. Rochelle? Thank you. Do you have 2 and 3 for me? Chapter 2 and 3? No. Somehow I missed it on Monday. No. I'll come back to you on next week. Okay. Neve? Thank you. Shakima? Thank you. James? Vanessa? Thank you. Christopher? Julius? Dwayne? Maya? Maya, do you have 1, 2, and 3 for me? This will be on page 181, I think. 181. Two and 3. Okay, thank you. And 3? Thank you. Vita? Lucille?
90.
Thank you. Asia? Thank you. Charlene? Shelby? Adam? Thank you. Faith? Okay. All right. I'm going to take these two because I don't think they're coming. Okay. All right, so let's review the body systems really quickly. This isn't about knowing that the respiratory system is made up of your trachea and lungs and bronchi and alveoli and all. That's not what this is. They're not going to ask you test questions like that. They're just not. That is important when you get into nursing. However, those of you who are going on for nursing, you're going to learn a lot about body systems. You'll have an entire year of prereqs devoted to anatomy and physiology 1 and 2 before you can even get into nursing. So you're going to know this down to a cellular level. But as CNAs, we don't need all that. What we do need to understand is how aging affects these body systems. So remember on Monday, we were talking about the effects of aging on the fat layer under our skin and how that affects our ability to do our job because the patient's going to perceive temperature different than we do. So we want to make sure they're checking the bathing water. It also means that they're going to be injured a whole lot quicker than we are because they don't have that protective layer there to help pad against injuries. Does that make sense? Well, the skin is just one body system that's affected by aging. So the way I like to explain this is if you imagine a factory for a second, because your body really is a factory. It's actually a lot of little different factories all together. So think of your body as a factory, okay? If I were to invent something, we'll invent this, okay? If I were to invent something like this and I wanted to have it produced so I could sell it, I am going to have to get a factory to produce this. So I go tour 2 factories. One of them, state of the art, everything brand new, works super efficiently. All the pens that come out of it are perfect condition, right? High quality. And then I go tour a factory that's 90 years old. Old, broken down, outdated technology, rusty gears, only works half of the time. And even when it does work, what it produces isn't all that great because it's old. Which factory do you think I want? The new one. It's going to give me the best product. Does that make sense? All right. So as we age, if we're a factory, our entire factory ages with us. So the easiest way for me to explain this is starting at the brain. Okay. So your brain is a factory. It's a memory making factory. So when your brain is shiny and new and everything is working perfectly, state of the art, it's going to produce really good quality memories that are going to stick around forever because the factory that made those memories was a brand new good factory working at peak efficiency. But as we age, that memory making factory ages with us. So when we get to be 70, 80, 90, that memory making factory is no longer state of the art. It's no longer working at peak capacity. And it may make some memories that don't stick around very long or are faulty or that may not even make memories at all right now because it's kind of offline because it's an old factory. Does that make sense? This is why we can have somebody that's older that remembers the shoes they wore to a piano recital when they were 12, but has no idea whether they had lunch. Because the memory that had to make, or the brain that had to make that lunch memory, not working right now. Does that make sense? Guys got that? So when we're working with older individuals, we need to understand that they may ask us the same question over and over and over again. It's not because they're trying to try our patience or be difficult or something. It's simply because their memory making factory totally offline right now. Don't get mad at them. It's not their fault, right? Does that make sense? Well, every body system in our body is a factory. It produces something for our well-being. So we're going to go through all of these factories, figure out what they produce and how that can be affected when the factory ages and isn't working optimally. Good? That's what I need you to get out of this, because that's going to affect how we work within our patient's needs, how we're going to accommodate it. So let's start with the nervous system. So we just talked about the memory part of this. Your brain does a few other things, though. Your brain is also responsible for your senses, like sight and touch and hearing and smell. All of those things are going to be affected by the brain's aging. It's not just the brain, though, because the nervous system is made of your brain, your spinal cord, and all of your nerves. You have nerves all over your body. Have you ever heard somebody say, you're getting on my last nerve? You're really not. They've got lots more. Keep going. Okay. So this means that as we age, our eyesight might be impaired. So it may be harder for us to see fine details. So we may need brighter lights where you can get up in the middle of the night and walk to the bathroom because your eyes can accommodate to the darkness and get that little bit of light to light your way. As we get older, we may not have that ability. So we might be a fall risk if it's dark. So maybe night lights might be a better option, or some sort of floor illumination might be a better option. Hearing might be affected. So have you ever worked with an older person that was hard of hearing? That is because our senses tend to diminish, remember they're factories, as they age. But one of the ones that really surprises me is the sense of taste and smell. Now, these two are tied together because if something doesn't smell good, it's probably not going to taste good, right? So these two are tied together. If you've ever had a cold and had a stuffy nose and couldn't smell, it affects your appetite. You don't want to eat because smell and taste are tied together. Does that make sense? Good. Well, if our senses are diminishing with age, that means a sense of smell might diminish as well. Patients may not smell as effectively, but that's ultimately going to affect their taste as well, which can affect their appetite. So a lot of older individuals don't eat very well, and this is a big reason why. So we want to offer small meals throughout the day. Okay, little snacks. We want to try to get as much nutrition in them throughout the day rather than just big meals, breakfast, lunch, dinner. Good? Makes sense? Decreased coordination. Yeah, because those nerves, of course, age. Well, the signal, because we're hardwired, we have an actual physical nerve that goes from my brain to my big toe, a physical line. Well, over time, that line gets all corroded and built up with gunk. And now the signal can't get from my big toe to my brain very quickly at all. So if I stub my toe when I'm young, I'm going to pull my foot back, hop around, and ow, 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 ow. But if I stub my toe when I'm older, It may take me a couple of seconds to realize that that has even happened. So the risk for injury here increases because our reflex are decreasing. Does that make sense? Okay. It also affects your coordination as well. Memory impairment, we've already talked about, and decreased concentration. Now, I'm starting to get this. I am a hyper-focused individual. Hyper-focused. When I'm sitting down at my computer and I'm working on stuff, I am 100% focused. As I get older, I'm starting to realize that it's harder for me to maintain that level of concentration for a long period of time. Now, you guys take this all for granted because remember, all of your brains are still new. You haven't really experienced this yet. So it's important to understand that you really don't have a frame of reference here. You will assume that your patients, your older patients, are just like you if I don't point all this out. So when we're talking to an older person and they start to look over there and what's going on over there, and you're talking to them, it's not that they're dismissing you. It's not that they are not interested in what you have to say. It may just be because their concentration level has decreased. They're not able to stay present. So shorter conversations or bring them back into the conversation. But what we don't want to do is, aren't you listening to me? I just told you. We need to understand their limitations and communicate with them where they're at, not expect them to be where we're at. Does that make sense? This is all kind of, once I say it, it's kind of, everybody's like, yeah, well, no, duh. We know that. But you probably wouldn't have stopped to think about it if I didn't bring it up. Okay. Cardiovascular, yeah, this system definitely changes with age, but this is one that you may not pick up on right away. Now, memory, concentration, slower reflexes, we can see that. That's very visible to us. But this, the heart and blood vessels, these are kind of hidden from us. And a lot of times these signs that things are changing are really hard to pick up on because they're small. But together they have a huge effect. Decreased endurance because our heart isn't beating as hard anymore, right? Your heart's a muscle. It's got to contract to push the blood up and out because it's fighting gravity. It's got to really contract. Well, over time, that muscle gets weaker and weaker and weaker. And now our heart's just kind of going, It's not really going woof, woof, like it does when you're young. So we end up with decreased endurance. So our muscles aren't getting the blood that they need as effectively when we're under physiological stress. So we're not able to accommodate as well. That means that we can't walk as fast. It means that we can't work outside as long. It means that we may not be able to sit up as long as we used to. You're going to have decreased endurance. You can also have a little bit of shortness of breath as well, because it's all of that effort. Okay. Higher blood pressures. Yeah, our arteries are getting all built up with all kinds of gunk. We're going to talk about that today in detail. So that means that our blood pressures tend to go a little bit higher, the amount of pressure inside that artery. Prolonged bleeding can happen because our platelets aren't working like they should to stop bleeding. Fragile vein walls. Yeah. And this has a lot to do with that lack of fat under the skin. So if you hit a layer of fat, it's going to cushion. If you're hitting the vein, yeah, it's going to split and we're going to get some bleeding under the skin. We call that bruising. Respiratory system, decreased lung volume. Your lungs just don't inflate the way they used to. They're not as elastic. Less endurance, especially on exertion and shortness of breath. We talked about that. Guys, the heart and the lungs, think of them, the heart and the lungs, kind of as they're two different body systems. They each have their own job to do, but they're very, very closely related. They're like fraternal twins. Okay. Very closely related. Whatever happens to one is going to affect the other for sure. They're best friends. The endocrine system, this is one that most people don't really think about too much, right? We know about the heart, we know about the lungs, we know about the brain. Those are the big ones. We know about muscles and bones. The endocrine system is one of those that people are like, huh? Yeah, I know the word. I've heard that somewhere, but I don't know what it does. I have no idea what it does. The endocrine system is responsible for producing hormones. Now, hormones, we tend to think of teenage hormones. Those aren't really the ones I'm talking about here, although it does produce those as well, but that's just like this much of its job. Hormones regulate everything. They're kind of like the messengers of the body. This is how information gets from one place to another, is through hormones. So hormones affect your metabolism. Hormones affect your digestion. Hormones affect your heart rate. Hormones affect your the amount that you sweat. Hormones affect your hunger. Hormones affect your tiredness. The hormones affect everything in your body. This is probably one of the most important body systems, but it's one of those that doesn't get much love. Nobody really talks about it. Nobody really thinks about your hormone system. When we talk about hormones, we do tend to think more about sexual hormones. Those are just like this much of what your body, your endocrine system does. But as we age, of course, the endocrine system is also going to age, and we're going to get some decreased hormone production, which means our endurance is going to go down. Our hunger is going to go down. Our need for sleep is actually going to go down. All of those things that the endocrine system regulates is going to be affected. So we're going to end up with sleep disruptions, decreased bone density, reduced metabolic rate, digestion issues. And you'll hear a lot of people say as they get older, oh, I used to love to eat pizza, but I can't eat it anymore. Or I used to love garlic. Yeah, don't put garlic in my food. And it's because of all of these changes in the body that your digestion system, your endocrine system, all of those areas are affected, and it will affect what your patient can and cannot eat and how much they sleep. Me, I like sleep. Oh man, do I like sleep. Leave me alone and I'll sleep 9-10 hours a day. Easy. I like sleep. But I've noticed as I'm getting older, my sleep is getting disrupted. I am now up probably about 4 to 8 times a night I wake up. And it all has to do with my hormone levels, hormone production, my endocrine function, my neurological status. So as you age, all of this is going to play a part. So what we find with older people, with a lot of them, is they can get by on way less sleep than you can. Now, this is important to understand. If I am sleepless, if I can't get to sleep, making me stay in bed, forcing me to stay in bed is not helpful. Just because I'm in bed doesn't mean that I'm going to be able to sleep. It's actually better for me to get up and walk around and do something and take care of whatever's on my mind and then go back and try to sleep. I will be much more effective. But in a clinical setting, we tend to do this on patients. It's 3 o'clock in the morning. Johnny wants to get up and you're like, Johnny, go back to bed. You're not allowed to be up. Says who? If Johnny doesn't want to be in bed, Johnny does not need to be in bed. You need to provide a safe place for Johnny to be. But don't assume that your older individuals have the exact same sleeping habits you do. They don't. Good. This is probably the number one reason that side rails are used, is to keep patients in bed when you don't want them up roaming around. Well, they need less sleep than you do. So just because you think they should be in bed doesn't give you the right to put side rails up to keep them there. Make sense? Starting to see things a little different? All right. Urinary system is obviously changed with age. Urine is going to, the bladder is going to hold less urine. Again, it's a muscle. It gets floppy as it gets older. It's going to hold less urine, which means they're going to have to pee more often. And when they do pee, their bladder isn't going to contract to push all of the pee out as effectively. So they're not going to completely empty their bladder. So not only do they have to pee more often, but they're going to have to pee more often. Okay, make sense? The valve that holds the bladder closed at the bottom of the bladder, there's a little valve there that holds it closed. That tends to get floppy with time too. So we end up with a little bit of incontinence here and there, or maybe a little more than a little. All of these things can affect us as CNAs because remember, toileting is a big part of what we do. Big part of what we do. So your patients are going to hit the call light, got to pee, you can take them to the bathroom, help them go, get them back into their chair or into the bed or wherever they need to be. And then 15, 20 minutes later, they hit the call light again, I got to pee. And you're like, I just took you. Well, it's not really their fault. Their body doesn't like them anymore. Be nice. They're probably just as frustrated with this as you are, because remember, they have decreased endurance. So every time they have to get up and go to the bathroom, it's taxing on them. They don't want to go any more than you want to take them. And yet, here we are. So don't get mad at them. Help them. Good. Skin, we've talked about this, right? The lack of subcutaneous fat under our skin. But the skin is also affected in other ways. And we talked about brittle nails with hand and nail care. The skin is thinner and drier, so needs more lotion. But you also get changes in hair color, right? And there was a meme a long time ago that I found kind of funny. And it's like, as you age, right, your body has to pick and choose what it keeps alive. Like, nope, we're not making hair color today. We want to keep the heart beating. And that's really kind of an accurate representation because everything is winding down. So hair color is one of the first things to go. We end up with white or gray hair because of this. But you also get changes in pigment of your skin. You'll end up with dark spots or mysterious light spots. It's like, what happened here? It's like, what happened? Like, I used to be tan there. Now it's not. What happened? And that's just because those cells that produce that pigment, they're done. They checked out. They retired. They're still there. They're just not working. Okay, so we're going to have all kinds of changes. Reproductive changes. This is pretty self-explanatory. Hormone levels decreased. Sexual drive can decrease, not necessarily. We are sexual creatures. We tend to have sexual needs and urges throughout our lifespan. So keep that in mind. Just because somebody is in a clinical setting doesn't mean that the drive and desire has completely left the building. So you will have occasionally sexual situations that you will encounter. We don't gossip, by the way, but who do we tell? The nurse. Yeah, but as our hormone levels decrease, this causes all kinds of havoc. Hot flashes, night sweats, decreased moisture production. We can have some dysfunction in our sexual processes. And of course, decreased fertility shows up here as well. And this is universal for men and women, decreased fertility. Notice it doesn't say fertility is eliminated, it just says decreased. So yes, you can have people, men that father children into their later years. It's less common, but it does happen. That's important for you to know because you may be caring for an 80-year-old man and a young man comes in to visit in his late teens, early 20s and says, this is my dad. And that may be. Dad may have fathered a child into his 60s or even 70s. Gastrointestinal system. This is probably the most common complaint that your patient is going to have. This affects them. Now, everything we talked about does not sound like a picnic, does it? Does not sound like a walk in the park. But this is the one that affects our patients the most because we tend to like what we eat. We tend to derive enjoyment from eating, not just nutrition. And as our digestive system changes, it's going to affect what we can and cannot eat and how much we enjoy that. So think about how much you like pizza. Now think about how bleak life would get if you couldn't enjoy pizza anymore. And this happens to a lot of your patients' foods. So we may have to get substitutes for dietary trays. If a patient says, yeah, I can't eat fish anymore, I just can't. We may have to contact the dietary department and ask for an alternate tray. But who would we want to tell? The nurse, that's right, because the diet order probably needs to be changed. So we don't have this problem again, okay? Then we end up with the musculoskeletal system. Now this one is pretty visible, right? These are the muscles and the bones that hold us up, help us walk. Bones become brittle, and this actually has more to do with the endocrine system than anything, those hormones. Bones become more brittle, so if our patient falls, they're much more likely to become seriously injured. Broken bones, dislocations. You also get decreased muscle mass. So the muscles tend to shrink in size and strength. So it's a whole lot harder to stand up and walk somewhere because we don't have the strong muscles that we did in our youth. Inflammation. Yeah, I'm right there. I got that one going on. Inflammation in joints can lead to stiffness and difficulty with mobility. And this is a big one. Let me tell you, 10 years ago, I would have told you arthritis, no big deal. No big deal, right? A little pain, a little stiffness, but you can get through it. Like I have broken my foot before and drove home from Miami. Like I have got a really high pain tolerance, really high. This will sideline me. So when people talk about arthritis, they are not kidding. And I didn't really realize. Now, as a nurse, you'd think I would know this, right? I didn't realize it until it actually happened to me. And then it's like, whoa, this is way more painful than you think. So when your patient says, oh my gosh, no, I can't do a shower today. I'm hurting too much. Be careful not to judge them from your seats. Because if you don't have experience with this, you don't know just how painful it actually is and how much of it, your strength it can take from you just fighting that pain. So all of this whole lecture, guys, have you noticed, is designed to make you a little bit more empathetic with your patients and a little bit more patient with them, give you a little greater understanding of where they're coming from. And that's what's going to make you a great caregiver. Okay. So the musculoskeletal system does have changes of aging. Arthritis is probably the biggest neon sign on there because most of our patients are going to have some form of arthritis. But you also end up with instability and coordination problems. And this is like everything working together. So in order to be coordinated and stable, right? Your neurological system has to be affected. Your cardiovascular system has to be affected. Your respiratory system is affected. Your musculoskeletal system is affected. Your endocrine system, just for you to stand up. Every body system is involved in that. Now, we don't really think about that, right? We just stand up. It doesn't really... But if all of those factories are affected, if your bones are more brittle, if your Your reflexes are slower. The signal traveling from your brain to your legs is slower. Your muscles have decreased in strength. Your bones are more brittle because of the decrease in hormones. If all of that is working against you, do you know how much it's going to take you to stand up and to stay standing? Pretty big, isn't it? Now, think about how many times you stand up every day. That can be exhausting. We need to be aware of this because it is going to affect your patients. There's some things we can do to help. We're going to learn that along the way. Okay. All right. And then we have the lymphatic system. Now, lymphatic system, this is kind of the hidden system of the body. Nobody really talks about it, but it is super, super important. As you go through your daily activities, you get fluid in places it shouldn't be. It's just how your body works. Anybody ever stand for a long time and get your legs to swell, your feet swell, right? That's fluid in the wrong place. Now, what happens is your lymphatic system, kind of the unsung hero of our body systems, your lymphatic system grabs all of that excess fluid, cleans it up. So it's kind of like the recycling center of your body, cleans it all up and puts the fluid back in circulation where it's supposed to go. I love the lymphatic system when it's working properly. When it's not working properly, it is a nightmare of epic proportions. But your lymphatic system is affected. So as we get older, we end up with more swelling in places. You end up with more infections, a lowered immune response. And that's primarily because the lymph system cleans that fluid, gets rid of all the icky stuff out of the fluid, like pathogens, before it puts it back in circulation. Well, if that system is offline, we can end up with pathogens that just run amok in our body. So that affects our immune system. Pretty cool. So all of these systems work together to keep us the healthiest we can be. And that's what I need you to understand, is that aging affects all of them. Now, it doesn't affect everybody equally. Does not affect everybody equally. My best friend's husband, this is kind of a extended thing. My best friend's husband, his grandmother lived to be in her 90s. And in her 90s, she was still driving. She was still playing bridge. She was still cooking and cleaning for the entire family. And she took care of her great-grandson every single day, a toddler at 90 something. That's pretty impressive. I don't think I could do all that at my age, right? That's pretty impressive. So understand there are always outliers. There's always people that are going to beat the curve, right? I'm not saying that she didn't have issues, but she was able to, they were minor. She was able to overcome them and live a perfectly full life. Now, I also know 30-year-olds that are stuck in bed because their bodies are completely failing them. So remember that this is not a one-size-fits-all scenario. These are the common effects of aging. It doesn't mean that every old person is going to experience all of them. Okay? So I want to review some of the skills that we learned over the last week and a half. Do you guys realize today is the halfway point? Told you it goes fast. It goes very fast. All right, so let's review some of the skills that we've learned up to this point, because we're going to add 4 new skills on today. So a lot to cover. So when we are taking a pulse, what do we need to support? The elbow. Sure. The elbow always needs to be on the bed. You want to support the wrist too. You don't want it just kind of hanging there, but the elbow is super important, because when the elbow comes off the bed, now all of these muscles have to be engaged to keep that arm up. Engaged muscles require more blood. More blood elevates the heart rate. And if that's what we're measuring and we're elevating it, are we getting an accurate number? No. So our pulse rates are always reported over what time period? 1 minute. But we always follow the care plan because sometimes we can take some shortcuts. What is a normal pulse rate? 60 to 100. And what areas of our fingers should we use to take the pulse? Fingertips. What finger should we not use? The thumb. And where's the radial pulse located? Okay, the bendy part of the wrist, below the thumb. Is it down here on the pinky side? No. How do the evaluators know when we're counting? Yeah, we say start and stop. And in Florida, how many evaluators do we count with? 2. If we count something, what do we have to remember to do at the end? Document it. Yes. All right, when we're dressing a resident, what are we going to ask them? Yeah, we need their clothing preferences. When should we get the clothing, by the way? Before or after we undress them? Before we undress them. Yep. When we lift a body part, how do we lift it? From above or below? From below. And what do we need to do while we're lifting to those joints? What do we need to do? Support the joints. Very good. Very good. Now we're going to get into the actual dressing process. So how do we know which arm to dress and undress first? So we're going to undress the strong arm first and dress the weak arm first. Very good. Very good. Don't overextend or force movement. Remember, no broken ankles, please. Okay. We want to adjust the clothing for neatness and appearance. Make sure all the buttons are buttoned right. All the toe seams are across the toes, not this way. You want it this way. The pants are over the backside, sitting at the natural waist. You know, make them look nice. And where do the soiled items go? In the hamper. Where do we want to put that call light at the end of the skill? Stronger hand. Hand and nail care. Our care plan is going to tell us this, but how many hands do we have to wash? 1. That's because the care plan says 1. What if the patient has 2? Follow the care plan. I don't care if they got 10 arms. That would be something, wouldn't it? But we're only going to wash 1. So when we're moving a hand, from the basin to the towel and back to the basin and all of that, what do we need to be careful to do while we're moving? What do we need to provide? Support. That's right. So we don't want to just grab the wrist, pick it up, and move it. Support from below. Always support from below. So we're going to soak the hand in water. Whatever we wash, whatever we rinse, we dry. Very good. This is something I didn't go over. I want to talk about. These reviews are good for me too. When you put the hand in the basin to soak it and then you take it out to wash it, because remember, you don't want to wash in that basin because we need water for rinsing. So we're going to take it out to wash. We're going to put the soap on the washcloth. No drippy, wet washcloth, so we really want to wring that washcloth out. But when we take that hand out and put it over here to wash it, we don't want it just on the barrier on the table. We need it on a softer surface. So I'm going to place it on the towel because that's a softer surface. Okay. Remember, less fat means more risk of injury. So we want to be careful here. We want to be gentle. So when we clean underneath the nails, which edge of the orange stick are we going to use? The slanted end. Yeah, beveled end or slanted end, not the pointy end. Don't stick a pointy end underneath the nails. And what do you want to do in between each nail when you're cleaning under? You want to wipe it. Yep. We want to use an emery board to file those nails to a manageable length. But how do you file? One direction toward the center. And then we apply lotion first or last? Last. Very good. All right. Making an occupied bed. Where does the patient need to be when we're making the occupied bed? In the middle of the bed. So because I need them to take up the least amount of space in the middle of the bed, we're going to have them on their side in the middle of the bed because we take up less room on our side than we do on our back. On their side in the middle of the bed. How do we remember which rolls which way? Clean rolls, dirty rolls away. Very good. Where should we be anytime we turn a patient over? In front of them or behind them? Behind them. Yeah, remain behind, the patient's behind. What do we not want under the patient? Wrinkles. We're going to make hospital corners. And then we want to loosen the sheet over their toes or feet. Yeah. And then we want to replace the pillowcase with the opening facing away from the door. Range of motion. Remember, CNAs do exercises to retain function. So we don't like pain. Remember that. We don't like pain. So we lift extremities from below with a flat palm, always from below. How many points of support at the joints? 2. Right. So if we're lifting the arm, we have to support the elbow and the wrist, not just the elbow. The wrist will flop everywhere. We're supporting the leg, knee, and ankle. Remember, 2 points of support. We want to move slowly and smoothly, and we always have to return to the start position. Flexion extension is what motion? Up, down. Abduction, adduction. Side to side rotation. Around. Good job, guys. Now, everything that we just did, all of those fill in the blanks, those are all on the flashcards. So everything you just saw is on those flashcards, along with all the fill in the blanks on the principles that we've learned and all of the supplies. So if you're making your own flashcards, you want to replay this video, pause it, and make sure that you're doing your fill in the blanks so you can answer all of those. Guys, if you follow this program, you will not just pass the state exam, you will get 100%. The evaluators, they absolutely love this because everything they're checking off is what we just went over. Okay. I actually had an evaluator from Texas call me about a month ago to tell me just how much, now this is Texas, just how much he knew who had used us to prepare for the test and how much he loved watching our prepared students test. Pretty amazing. So I'm telling you, this program does work, but you do need to make sure you can answer all of those fill in the blanks so that you can be successful. Okay, good. All right, so now we can move on to some new skills. Turn to page 138. If you look on page 138, you can see we have our principles related to this particular skill, but we also have the principles going down the side that are involved in this skill. So, of course, we're going to follow the care plan. We're going to do our opening. We'll evaluate if we need gloves. We're going to use a barrier on the table. Our patient is uncovered for this skill, so we need a privacy blanket. We're working with linens, so we want to make sure linen rules apply. Scoot and roll. That means patient always needs to be in the middle of the bed. And after the turn, we need to be behind them. And we're going to do the closing. So there's not really much for you to learn here. Okay. Not really much for you to learn to do this particular skill. You've got the principles, the building blocks in place to put all of this together. But I want to spend a little bit more time on scoot and roll because we just barely touched on it when we were talking about making an occupied bed on Monday. But I want to get into it just a little bit deeper because this is the main safety point on the state exam. Bed safety. Your patients are at risk if they're up walking around either with or without your help. Yes, they are at risk of falling. Absolutely. But there are fewer falls that way than there are from the bed. So we've got to know how to keep our patients safe when they're in bed. Make sense? Okay, so this is a really big topic for the state exam. So let's talk about scoot and roll a little bit more. So page 139 tells us our step-by-step instructions on how to do this skill. So let's go through this page really quickly. Up at the top, you'll see the care plan. Care plan tells us to position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. Unable to assist with turning. Get that there. Okay. So we have step-by-step instructions here. If you look at all of this, you'll see there's only 34 steps. Sounds like a lot, but remember a peanut butter and jelly was 42. This is easier than a peanut butter and jelly sandwich. You just got to do it once or twice to make it easy. Okay? All right. Something I want to point out here that you probably haven't picked up on yet, but I want to point it out to you. Do you guys remember on day one talking about the clinical checklist? This is the actual list that the evaluators are using when they check you off for your skills. You guys remember that? Okay. Well, when you're looking at these step-by-step instructions, at the end of every single line is a number. Do you see that? Like the end of number 1, it says read care plan, knock, and then it says 15A. So what I did when I was making this is I took this checklist and I looked at all of the steps involved. This, reading the care plan and knocking, you're going to get 15A checked off by doing that. If you go down to number 6, place barrier on overbed table, 13. That means that is a checkpoint. Checkpoint 13. You need to do that to get that checkpoint. So what I did is I connected the step-by-step instructions with the actual checkpoints that action represents. So when you're practicing, if somebody forgets something, forgets a step, they might say, "Oh, it doesn't matter. It's not a big deal." Well, if it has a number next to it, is it a big deal? It's a checkpoint. It's a checkpoint. Good? Makes sense? So I wanted to point that out to you because it's something that's not always intuitive. Something you may not have recognized. All right, so let's talk about scoot and roll, specifically restraints. So we touched on this a little bit in class on Monday, but remember that a crib is used to keep a baby confined. It's exactly what we do with side rails. It's the same thing. The only difference is these rails go up and down, these go side to side. It's the only difference. Does this work forever? Kid gets to be a year and a half old, what do they start doing? And that actually increases their risk of, falling, injury, because they are going to fall from a further higher position. Do you think this works? No, what we've actually done is cause them to fall from a higher position. So we can't rely on side rails alone to keep our patients safe. And the thing is, we actually don't need them. You don't need side rails. You don't. And I'm, again, going to prove it to you. How many of you guys sleep in a bed? How long you been sleeping in a bed? Yeah, sorry. Since you were about 2 year and a half, 2 years old. So when you are taken out of the crib and put into a toddler bed, mom probably put something soft on the floor just in case you fall out until you learn, right? We might have those little half rails. But the whole point is that somewhere between 1.5 years and 3 years old, you learn how to sleep in a bed. Now you go to bed, you go to sleep, you are not aware of anything, dead to the world, right? And yet you don't stay in the same position all night long. You toss and you turn and you stretch and you move. Well, if you're asleep, how in the world are you staying in bed without side rails? You ever stop to think about that? You're asleep. You have no idea that your body is moving as much as it is. But yet you stay safely in your bed. How does that happen? Well, way back when you got into that toddler bed between 1.5 years and 3 years, your brain develops something called spatial awareness. Now, spatial awareness actually starts to happen a little earlier in life, but somewhere between 1.5 and 3 is when we really cement it in, and it's good. And what this means, this is a very small part of your brain that is always on. It never goes to sleep outside of 2 situations we'll talk about in a minute. It's always on. Even when you are sleeping soundly, it is always on. And this part of your brain is responsible for knowing where you are within the space you have to work with to keep you safe. Now, I said there's 2 times that this little area can go to sleep. One of that is with medications. Have you ever gotten a medication from the pharmacy and it's got that red sticker? It says may cause drowsiness, do not operate heavy machinery. Yeah, that's because we know that that particular medication can put that part of the brain to sleep. So you're not as coordinated. The other thing that affects that part of the brain, spatial awareness, the other thing is alcohol. This is why you can sit on the bar stool at the beginning of the night, but by the end of the night, that bar stool represents a challenge, right? Our coordination is affected, and that's because that little part of the brain is affected by alcohol as well. Now, outside of that, that little part of the brain is always on and always working. So that means that you can go into bed, you can go to sleep soundly, and still wake up in that bed because that little part of the brain did its job. Great job. Now, it's not dependent on the size of the bed because you probably nap on the couch once in a while. It's a much smaller space than your bed, and yet you don't fall off the couch. And it's not even dependent on familiarity, right? Your bed, your couch, you know how big they are. Your brain knows, and that's why it keeps me safe. It's actually not true. It's not based on familiarity. Have you ever gone to a hotel or a friend's house or a cruise ship and slept in a bed that you're not familiar with? No matter how big or small that bed is, you tend to be able to stay within its confines even when you're sleeping. Now, the good news is you take that ability with you everywhere you go. It's actually what allows you to stay sitting in these chairs without being on the edge, falling off, tipping over backwards. This spatial awareness you're actually using right now. It goes with you everywhere you go. So just because a patient has gone to a medical center of some sort doesn't mean they left their spatial awareness at home. Good? Makes sense? So your patient can, for the most part, stay safely in this bed without your help at all. We don't need side rails to keep them in bed. Their own brain will do that for them. Now, but I did say that this is affected by two things. Alcohol, which we're not serving. Okay, so that's not going to be a factor. But medications can affect this. So in the event that your patient is on a medication that affects spatial awareness, the nurse would recognize that and have some sort of a accommodation in the care plan. The system is already there. We're not inventing it. We would just follow for that patient. I'm not talking about those outliers. I'm going to talk to you about our normal, everyday patients that are not affected. They do not need side rails to keep them safely in the bed. Good? I get thousands of comments on my YouTube channel. Literally thousands. This is probably the one I get the most comments on. You didn't raise the side rails before you went and washed your hands. No, I didn't. I didn't need to. Patient is perfectly capable of laying in that bed all by themselves without side rails, unless the care plan says otherwise. And newsflash, this care plan did not say otherwise. So did I need to raise the side rails before I washed my hands? No. So what this shows me is someone was told something, but all of this background was never explained to them. So do they truly have enough knowledge to be effective out there in a clinical setting? No, they're just going to be putting side rails up everywhere. And that actually can lead to more risk of injury for our patients. So you see how sometimes a little bit of knowledge can be very, very dangerous if it's wrong? That's why I have to go through all of this, because I want to make sure that you have the right information and we're overcoming some of the wrong information you may have picked up on along the way. Okay. All right. So now that we know our patient has this ability built in, no problem. If they don't, it's going to be reflected on the care plan. Now that we know that, I want to talk to you about a very special class of patients called immobile patients. Now, patients that are immobile means they cannot move on their own. Either they had a stroke, or they're paralyzed, or they have some sort of a degenerative muscle condition, or for whatever reason, they cannot move on their own. Now, I want you to kind of think about yourselves sitting here. Okay. You are in this room. We have been here for an hour and 5 minutes, and you are not sitting in the exact same position that you were sitting in an hour and 5 minutes ago. You have shifted and moved and stretched and crossed your legs and leaned your head and all of the things that you do, right? Why? Why? Why didn't you just come in, sit down, and stay perfectly still for the last hour and 5 minutes while I've been talking? Why do you move? And see, I was that kid that drove my mom nuts with why. Why is the sky blue? Why does a turtle go slow? Why? 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 And I drove her nuts. She bought me encyclopedias back when encyclopedias were a thing, because I drove her nuts with the why. So I've always wanted to know the why, but that is actually what's going to make you guys better, because I know the why and I'm going to share it with you. The reason that you guys are not in the same position has everything to do with gravity. So on planet Earth, we have gravity, and gravity is pulling everything down. Gravity is trying to get us to the center of the Earth. That is its job. Now, thankfully, it's not like super, super effective at it. Otherwise, we would be in the Earth's core. But gravity exists to pull you down. Good? Everybody knows about, Newton and the apple and all of that. Well, that actually causes a problem in human bodies because as I'm standing, right, the Earth's gravity is trying to pull my entire body weight down through the soles of my feet. So my whole body weight is being pulled down through that one small area of my body that's touching the floor. You guys, gravity is trying to pull your body weight down through your butt and thighs because that's where you're sitting, right? So your entire body weight is being pulled down through that lowest point. Good? Makes sense? That gets uncomfortable because as your body weight is pulled down, that means that the weight is pressing down on those blood vessels and muscles and fat and skin. All of your body weight is compressing all of those layers down. So your body compensates by saying, hey, shift, move, jiggle your foot, rest your head. Your moving, minute movements are designed to relieve that pressure and promote blood flow. Make sense? So we're going to do an experiment here together so I can explain to you the effects of immobility on patients that cannot move in little minute movements to relieve that pressure. Okay? So we're going to do an experiment here. So immobility, the inability to move on your own, of course, it's going to affect your muscles. It's going to affect your bones. Yeah, absolutely. But it actually affects every body system in ways that you have no way of really knowing about yet. If you can't move on your own, it's going to affect your digestion. And that's because our intestines they're smooth muscle. They don't contract on their own. So food moving through your intestines requires your abdominal muscles to move, to push the food through your intestines. This is why you're supposed to take a 10 to 15-minute walk after you eat. Do you guys know that? Yeah. Used to be years ago, you took an after dinner stroll, and it's for digestion. And that's because our intestines require that abdominal muscle movement to work effectively. So our digestive system is affected. Our lung volume, our rib cage can't expand well if we're laying down. You're not going to breathe in as much air. So that's going to affect your oxygen levels. That's going to affect your brain, your ability to think effectively. It actually affects your immune function as well. I mean, all of these body systems are affected when we can't get out of bed. This is another reason why we don't want to use side rails to keep somebody in bed, because all of this gets affected. It's not just as easy as saying, you're being a pain in my butt. I want you to go lay down. I'm going to put the side rails up to keep you there because I don't want you wandering because I've got work to do. Well, what you've done is created a whole bunch of problems for your patient. That's not the right answer. Good? Now, when our patient is immobile, all of this is going to happen anyway because they're immobile. But one of the biggest areas that's affected is the skin. So to show you this, to demonstrate this, I want you to take one hand and put it underneath your leg for the next 2 minutes. You're going to want to pull it out. Okay? I'm going to ask you not to. Just play along for 2 minutes. You're going to want to pull it out. And I'll tell you when you can. I'll tell you when this is up. But this is an experiment to show you just how quickly immobility can affect the skin. So you're actually on a soft surface, which is pretty cool. I used to do this on those hard metal chairs. That was really uncomfortable. So stick with me here. All right. So for the next 2 minutes, we're going to sit on our hands. Now, every bony prominence in your body, so this is like the back of your neck, the tips of your shoulders, your lower back, your hips, the back of your legs, the back of your calves, and your heels. So all of these areas where it's bone over muscle, right? That bone is heavy. It's going to press down. So these are what we call pressure points. They're points of maximum pressure where a bone is going to press into a muscle just because of our position. Good? Pressure points. Now, what that means is as that bone presses down onto the muscle and onto the fat and then into the skin, it's actually going to compress. I don't know if you guys can see it. See these little veins here? It actually compresses those veins, and it's like a straw. If I have a straw and it's open, liquid can get through it. What happens if I pinch that straw off? No liquid gets through. So that means that we have areas of the skin with no blood supply. So what do you think that does to the skin? If we don't get blood to the skin, what happens to those cells? They die. That's a problem, isn't it? That's like a really big problem. So what we need to understand is if we have pressure from above, bones, muscles, fat, skin, blood vessels, and we have pressure from below, like wrinkles in our sheets, those wrinkles are going to press up as everything else is pressing down. And now we've got an uneven surface. Have you ever driven on a road where like part of it is paved and part of it is not, right? In that uneven surface, it actually makes your car kind of do this. And it feels very unstable, right? Well, that's kind of what we have here. We have a difference in pressure dynamic, which means more pressure is going to affect one area of the skin more than another, which can cause a line. We're going to get there. So the skin and the muscle is caught between these two areas, and without good blood flow, the tissues start to separate along that line. Okay, so go ahead and take your hand out. And I want you to look at it really closely. Do you see color changes? Now look really closely. Can you see the imprint of the chair or your uniform fabric on the skin? Can you see that? That only took 2 minutes. 2 minutes. And your skin was imprinted. Now, it's actually going to take longer for that to go away completely. 2 minutes is all that took. Now, imagine if I put your hand underneath your leg and you couldn't move it on your own because you're immobile and left it there, not for 2 minutes, not for 20 minutes, not for 2 hours, but 2 days. How deep do you think those lines would get? Make sense? Okay. So as we work with patients that can't make those minute movements themselves like you do, remember those movements are designed to restore blood flow to an area. If they can't do that, that means we're going to have to do it for them. And remember, you got lines at 2 minutes. So we're going to have to be very vigilant about this and turn our patients on a schedule. So for us, if 2 minutes did this, we're pretty healthy. We've got good protein intake. We've got a good circulatory system. We've got good muscle function. We've got good kidney function. We're healthy, right? So your body will accommodate for this pretty quickly. Within 2 to 3 minutes, all those lines will go away and everything will be fine. But in somebody that doesn't have a good, healthy system, this can take days to recover from. because we don't have good blood flow to the area, or good kidney function, or good oxygenation. So this can be a really big long-term problem. So this is why you change position frequently at night. And if our patients can't do that, we're going to do it for them. And we're going to do it every 2 hours around the clock. So that means that if we have an immobile patient, we have to change their position every 2 hours, even while they're sleeping. So at 2 a.m., we're going in and waking them up and turning them over. At 4 a.m., we're going to turn them over. At 6 a.m., we're going to turn them over. Don't let them sleep through the night thinking you're doing them a favor. Oh, I feel so bad waking Mr. Harvey up every single night, every 2 hours. I'm just going to let him sleep all night. Let him get a good night's rest. Well, if that's the case, those capillaries have been squished for 6 to 8 hours, no blood flow. What happens to cells without blood flow? They die. So when we go in to see Mr. Harvey the next morning, he is going to have a bed sore. That's what this causes. Because as that pressure goes up and up and up and up through those layers, it will actually cut into the skin and cause a pressure sore or bed sore. So when we're turning patients every 2 hours around the clock, we're going to use something called a turning clock. Most of the time, your facility will provide this. It'll actually be up on the wall above the patient's bed. But if not, you can make one. Perfectly okay for CNAs to do. That way, if I walk into the room as a nurse and I see a turning clock up on the wall, just like this, and I know it is, give me a time. Morning or evening, or morning or afternoon? 2 p.m. Okay. So if I know it's 2 p.m. and I walk into the patient's room, I know the patient should either be on their right side ready to turn, or they should be on their back because they were just turned. Now, if I walk into a patient's room that is immobile and they're on their left side, what does that tell me? Yeah, they're not being turned properly. Good? Makes sense? So you can use this. This is a turning clock, perfectly okay to use for CNAs. But most of the time your facilities will already have them. But let me explain how this works. We have a patient on their back, and after 2 hours on their back, we're going to turn them onto their right side. After 2 hours on the right side, we're going to turn them back onto their back. And then 2 hours later, left side. 2 hours later, back onto their back. Right, back, left, back, right, back, left, back. And that's because our back actually doesn't have as many blood vessels and nerves, and the muscles that we have are structured differently than the muscles on our front and sides. So we can have them on their back a little more often. Not for longer, but more often is fine. Good? Makes sense? Notice that nowhere on here does it say stomach. Do not turn an immobile patient onto their stomach unless our care plan specifically tells us to. Because if your patient is unable to move on their own and you lay them on their stomach, remember, gravity pulls down. So that means my entire body weight is being pulled through my lungs and heart. So I may not be able to lift myself off my lungs enough to inflate them. Does that make sense? This is why we tell new moms, don't lay baby on your stomach. We want them on their side with a rolled up blanket or on their back, because babies, all of their body system, all their factories are still being built. Just because a baby is born does not mean their factories are fully functional. They're still being built and going through the testing process. So if you put baby on their stomach, they may not have the strength to open up those lungs and breathe effectively. If we have somebody with a neurological or muscle wasting problem, If we have somebody that's paralyzed, stomach is not the right answer. Make sense? So how do we know as CNAs? What do we follow? The care plan. See, all the work has been done for you. You guys see that? Interestingly enough, this side note, COVID, I found this really fascinating with COVID. We found that with COVID patients in the ICU did better when we put them on their stomach. So that's very interesting. Some nurse somewhere experimented with this, and we actually found that they recovered quicker if we put them on their stomach. Pretty cool. And that's because of fluid dynamics and gravity. But the reason is different. Right? These people didn't have a neurological or a muscle disease. They weren't paralyzed. They could inflate their lungs. But what we wanted to do is get all of the fluid to shift forward to leave the bigger back areas of the lungs able to process. Good? Isn't that cool? The body is amazing. It is an amazing, amazing creation. So to remain safe, we need to make sure the patient is in the middle of the bed, even if we're going to be turning them. So if they have to be in the middle of the bed when we turn them, we talked about this on Monday, we're going to scoot them toward us and roll them away from us. And if our patient is able to do that on their own, they will. If they can't turn on their own, I'll ask them to scoot toward me, and then I will turn them. So it depends on what level of ability our patient has. If they can't do anything on their own, I'll do it all. Okay, but we're going to help them where they need it. So after a patient's been turned on their side, they should not be near the edge of the bed. This is what they're looking for on the state exam. When you get done turning a patient, because that's a skill we're going to do, we're going to turn a patient onto their side, use some pillows to keep them there. That's our skill. This is what they're looking at. They don't really care about the pillows too much. We're going to learn how to do them because they are important, but that's not the important part of this skill. Looking at your patient to make sure they're not too near the edge of the bed, that's the important part of the skill. So if you do this skill, you scoot the patient towards you, you turn them over onto their side, you get pillows all in place, and you stop and look at them, and they are too close to the edge of the bed, do not ignore it. That is what your evaluator is looking at. If the evaluator thinks that patient is too close to the edge of the bed, I don't care how pretty your pillows are, you will fail the skill. Good? Are you starting to see that this test has nothing to do with you? It has everything to do with the patient. Everything, 100%. 100%. Okay, so when we're scooting and rolling, we're going to scoot the patient toward us and then roll them onto their side facing away from us. And then we're going to use a few pillows to keep them there. But ultimately, after the turn, they need to be in the center of the bed. Now, if the person that you're partnered with is a little bit larger, this may take a couple of tries for you. Okay, because if they're a little bit larger, they're going to take up more of the bed, which means after the turn, they may be closer to the edge. So keep working with them. You can ask them to scoot back a little bit so they're in the middle, but the whole point is to address that, not ignore it. All right. So what if they're immobile and can't scoot towards you? For the test, they can. If you go back and look at the care plan at the top of the page, it says the patient cannot assist with turning. It doesn't say anything about scooting. Remember, it's the care plan, the whole care plan, and nothing but. So don't add words into that care plan. Don't add words into that care plan. Okay. So, but in a clinical setting, what if your patient can't? What if they can't scoot? What if they got a huge incision down the middle of their body and they just can't scoot? Well, we have a couple of tools that we can use. If I don't have any tools, then I'm going to use the segment method. I'm going to pull their legs toward me, their hips, their torso, their shoulders and head. So segments. May take me a couple tries because I'm moving little bits at a time, depending on how big they are. but I'll get them moved toward me eventually with little motions. But there's another way if we have another caregiver, and that's called a draw sheet. Now, draw sheets are really cool, but you really do need two people to use them effectively. All this is a sling. It's a sling. And it stays on the bed all the time. So a draw sheet is nothing more. I got to bring the linens down. I've got clean linens. I just keep forgetting to bring them. So let me tell you how a draw sheet works. A draw sheet is simply a regular flat sheet. You can create your own draw sheets at home. Just get a regular flat sheet. For small beds, twin works best. So if I have a regular flat sheet, instead of putting it on the bed, on top of the bed, like you would a normal flat sheet, I'm going to take this flat sheet and I'm going to fold it in half lengthwise. So this is the part that normally goes up here. This is the part that normally goes down there. I'm going to fold it lengthwise. So that means I'm folding it long ways. So I'm going to fold it up here. Remember, we don't snap or shake, and we don't let anything touch the floor. I try to keep it off my uniform too. So in clinical settings, these sheets actually come pre-folded like this. So people that work in laundry, there's actually a right and wrong way to fold sheets in a clinical setting. And it's opposite what you do at home. So we have this sheet that's folded in half lengthwise. So it would come folded like this from laundry. Okay. So I went and got my sheet from laundry. I have clean linens now. So in order to use this as a draw sheet, I'm going to unfold it just like this. And I'm going to position this sheet with the folded edge at the top. So see how this is the folded edge and this is the edge that goes together? You see that? The folded edge, ooh, fuzzy. The folded edge and the part that goes together. The folded edge goes at the top. So I'm going to lay this on the bed with the folded edge at the top. The part that goes together toward the bottom. And my patient will be right in the middle. So this folded edge goes just below their shoulders. The two halves that come together goes mid-thigh. And it's going to lay on the bed underneath the patient. This extra here would be tucked underneath the mattress. Now I want to try to reduce wrinkles because remember, wrinkles are going to press up into the skin, that uneven, bumpy road, and increase the likelihood of what? Bed sores. That's right. So I want to try to remove as many wrinkles as possible. So this draw sheet would be placed on the bed. If you have an immobile patient that cannot move on their own, it's going to be put on the bed with the folded edge at the top, the together edge at the bottom. We're going to remove as many wrinkles as we can, and now we've got a patient laying there. So we're going to pretend there's a patient there. Okay? So I have a patient in bed with a draw sheet. Now, if I have an immobile patient that can't move on their own, I would take this draw sheet. Patient is in bed. We have an imaginary patient. I would take this draw sheet. I'm going to untuck it from under the bed, and I'm going to roll it toward the patient. I would get another caregiver over there. They would do the same thing. Untuck it, roll it toward the patient. And now what I have is a sling. I can lift this up and scoot this patient toward me on the draw sheet. Good. So if I don't have a patient that can move themselves, most likely I'm going to use a draw sheet to accomplish that. I can use a draw sheet as a sling to get the patient moved up in bed, to reposition the patient in the bed, and we can even use that draw sheet to get the patient transferred to a stretcher. Because remember, it's a sling. Good. Now, there's another thing that we can use too, but these are like super expensive. You're not going to have them in every setting, but they're called slide sheets. They're super slippery. They're not wet, but they're kind of like a slip and slide, slippery without being wet. They're frictionless. So when you have a patient on a slide sheet, they literally just slide. But they're very expensive, so not all settings have them. So you've got different methods. How would we know which method to use for this patient? Care plan. Absolutely. Good. All right. So now that I've got the patient scooted toward me, and for the test, I'm just going to ask them, can you scoot toward me? Super easy. Now that I've got them scooted toward me and they're close to the edge of the bed, I don't want to walk away because they're close to the edge of the bed, but I've got them on their back close to the edge of the bed. Now I've got to prepare them for turning. Now, using this technique, you can actually turn somebody 2 to 3 times your body weight with no stress on you or them. But you've got to do it properly. You've got to set it up right. If you set it up right, I can turn somebody that's 500-600 pounds easy. And I used to all the time. I used to do home care for bariatric patients. These are patients that are too morbidly obese to leave their home. And I used to go in and change their position and teach their families how to do that to prevent bed sores and other complications. So the way that we do this, oops, sorry guys. The way that we do this, the way we prepare a patient for turning is, remember, we're going to remain behind the patient's behind after the turn, right? So I'm always turning a patient away from us. Good. So if I'm going to turn the patient on their left side, I'm going to be standing over here to turn them away from me. The furthest arm goes up. The closest arm crosses the chest. So if I'm going to turn the patient this way, furthest arm up, closest arm crosses the chest. If I'm going to turn the patient this way, furthest arm up, closest arm crosses the chest. Good. Going down to the legs, the closest knee is going to be bent with a foot flat on the bed. The furthest knee is angled out. So when you do this, when you have a hand up, hand over, knee bent, knee angled, the patient's already half on their side. And you didn't really have to do a whole lot of work there. So once I get the patient in this position, turning them becomes super easy. Hand on the shoulder, hand on the hip, and just like that, they turn without a whole lot of effort. Now, more importantly, it's not going to be hard on them because they're already in that position. Okay, good. Questions? So furthest arm up, closest arm over. Closest knee bent, furthest knee angled. So up, over, bent, angled. Up, over, bent, angled. Good. Questions? Okay. So we're going to roll the patient in the middle of the bed with the upper knee bent in front of the lower leg. You don't want those legs lying right on top of each other. Remember, gravity is trying to pull everything down. Well, if that's the case, now we don't just have one bone pressing down. What do we have? 2. So remember, gravity's pulling all that down. So what we want is the knees kind of offset a little bit so we don't have all of that pressure on one place. We're also going to put a pillow between those legs, specifically between the knees and the ankles. We don't want those bony areas rubbing together. So legs offset just a little bit and make sure there's a pillow between them. We were going to put a pillow behind the back too in a roll. Now this one, if you remember on Monday, I told you that gravity's always trying to pull back onto your back. You guys remember that? Gravity's always trying to pull the body weight back onto their back. Well, by putting a pillow behind the back in a roll, I'm keeping them in that upright position. So gravity doesn't have a chance to pull them back. Okay. There's another pillow we're going to put on the bed too. Now this one is going to go under that upper arm. So when you're laying down on your side, this arm does this. That offset puts a lot of stress along the upper back and into my neck. If you came over here and felt my upper back, it's very tense right now because of the position of my arm. This is neutral. This is stressed. So what we want to do is recognize that and put a pillow underneath that upper arm just to hold it in that neutral position. So now I've relieved all of that stress. I don't have muscle spasms and headaches. And then we have to look at the pillow that's already on the bed, the one under the head. Make sure that it's not under that bottom shoulder, scrunching that one up. We want the pillow under the head and neck only. Call light is always going to go in the bottom hand. We don't want a cord stretching across the patient's neck. That's safety. So call light goes in the bottom hand. Good? Questions on this? All right, I'm going to show you the video on this one because I normally do this one live, but I want you to see the close-ups specifically of the pillow behind the back. It's kind of hard to see how I tuck the pillow behind the back from this position. So let me show you the video on this, and then if you need me to run it through with you live, I will. Okay, and then we'll take a quick break. Oops, what happened there?
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to turn you onto your left side. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies, and I'll be right back.
Okay.
I'll start gathering your supplies. We'll start with a barrier, which I'll place on the table to provide a clean area to place my supplies. And I'll get 3 pillows from clean supply cabinet, being careful not to allow them to touch my uniform. Mr. Jones, I'm going to place this blanket over you, and this will help keep you warm and protect your privacy while we do this skill. Once I have the blanket in place, then I'll pull the sheet down underneath the blanket, making sure the patient remains covered at all times. Okay, Mr. Jones, if I could have you scoot toward me, please. I'm going to place your furthest arm above your head and cross your closest arm over your chest. I'm going to bend the closest knee and put the foot flat on the bed.
And I'm going to angle the furthest knee out a little bit. Okay, now I'm going to turn you onto your side. 1, 2, 3. Okay, I'm going to take the first pillow and put it in an angle up against the back, and I'm going to tuck this top edge underneath the patient by pushing down on the pillow and under his back. This edge will roll up, and then it too will be pushed down and under, forming a roll along the back. Okay, now I'm going to position a pillow between the two legs by lifting the top leg and laying the pillow lengthwise between the two legs, specifically between the knees and the ankles, to prevent those bony areas from rubbing together. This pillow is going to be placed underneath the upper arm. This will help keep the arm in a neutral position as the patient remains on their side. And then I'm going to adjust the pillow underneath the head to make sure that it's not under the shoulder and it remains only under the head and the neck. And then move the arm to a more comfortable position. Is that comfortable, Mr. Jones?
Yes.
Okay, I'm going to place the call light directly in your hand. Are you comfortable?
Yes.
Can I get you anything else while I'm here?
No.
Okay, let me pull your sheet up. And remove the privacy blanket. Being careful not to dislodge all of those pillows as I do so. I'll roll the privacy blanket up and place it in dirty linen. The barrier will be thrown away. Okay, Mr. Jones, I'm going to open your privacy curtain now. Is there anything else I can get for you while I'm here?
No, thank you.
Okay, I'll see you soon. Let me go wash my hands. After washing my hands, I'll review all the steps of my skill, make any corrections, and tell the evaluator my skill is done.
Okay, any questions on that? Any questions? Not bad, right? So the care plan, one more time, said to position the resident on his left side. Patient requires support to remain on the side and is unable to assist with turning. That's why we used all of those pillows as support. You don't have to use pillows. You can use rolled blankets. You can use positioning devices, which looks like little foam triangle pads. There's a lot of different things that we can use, but for the test, we're just going to use the pillows that are available to us. Okay. So now we're going to take a break before we get into foot care. I've got a lot to tell you about foot care. We have to talk about diabetes. This is going to be a little bit longer lecture. So let's go ahead and take a break, stretch, get your brain working again, get the blood flow back up, get a drink if you need one. There's your receipt. You're welcome.
a lot.
Yeah, all the nervous system, and diabetes, and cancer, and just everything.
Yeah.
That was a lot for me.
Yeah.
And the blood pressure we still have to go more.
Yeah.
Because when we had 10 minutes before class, I feel like that was a long time.
Yeah.
So,
Definitely. I like to remember.
oh yeah.
Are you going for nursing after this?
I think I'm going to work for a couple years at a CNA and then go to nursing.
Yeah.
Only because I don't want children too many. I just want to work a little bit.
Used
Because
to.
I feel like when you're working, you're also going to learn a lot of information on the job. So I feel like it would be easier to go into nursing school, you know.
I agree.
I think it would just be, easier just to not just go straight into it for me.
So you can
know
fix it. No, just CNA.
Yeah.
I do retail, so I'm trying to get out of that.
Yeah. I did retail.
Yeah,
That's a lot.
it is. I was doing overnights and then I stopped that 2 years ago and now I do full time, but I'm getting older and I want to try something different.
Right. Make a little bit more money too.
Yeah,
Yeah.
exactly.
Yeah.
Helping people will be better.
Like you'll be going to work like around here.
Yeah, hopefully. Yeah. You too.
Yes.
How long after the test she can go for, after the test she can go for the test? She doesn't even know when that yet.
Yeah, I think today she was actually gonna go over. I think she said register for the exam, so she's probably there for that. But also, it kind of depends on how people schedule the tests.
Yeah.
So it could be, and it also depends on your availability. So it could be next week, it could be next week. Not like next week, but when you've done like, I don't know, I was thinking the same thing, but I'm it just depends.
Yeah.
Because she says that they fill up fast, so I'm hoping it's not too long.
Right. Yeah.
Would you go to Tampa for the test? The skin exam?
Yeah.
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 That's probably she said the closest one. Unless you go up there.
Yeah. Which is Ocala. She said.
I think so.
Yeah. I think that would be further.
Yeah. I think I would do okay on the clinical part, but I feel like the test answer questions is gonna be a little harder
Yeah.
because I feel like if it's going to be questions on the chapter we just read, I feel like I'm just okay.
Yeah. Probably have to keep reading
Yeah.
over it and over.
And I'm probably gonna buy the flashcards.
Yeah, I did.
You did?
Yeah.
Did it come in handy?
Yeah. I went over them, but not with work and everything.
Right.
I figured too, if the test isn't right after this, my other day, like these days, I'll have to just
Yeah, study.
study.
Yeah. I'm thinking about it. They're already done, and she says I think it tells you this applies to her thing, so
Yeah.
I just feel like that would be easier. I mean, you could also make some too, what you need to practice on and learn more on. But I just feel like I should just buy them, so I'll probably buy them after class.
Yeah. I think they're helpful. Have you went online to see the videos and stuff?
Not yet. No, I did
I think that
look
would
on
be,
the website,
Yeah.
but I feel like maybe I should do that too.
yeah,
Keep watching the videos to
Yeah.
see. Yeah. I know I just told her about the email because I was getting the last two
I'm
emails
glad
now.
you brought that up,
Yeah,
because I didn't either,
Yeah.
only the first one.
yeah. So I told her about that because I know she was going to send videos of what we went over in class and review, so that would help to the link instead of finding it on the website.
Yeah, yeah, I'm glad you brought that up.
I thought I got the first one on Monday. I got the first one, and I thought on Wednesday I got that one too, but
Yeah. I got the application one, I should say, and then after that, I didn't.
right.
So basically for the test, we had to do one of these three skills. I guess, right?
Yes.
So we got to make sure we know how to do all of them.
Yes, I think it's going to be for sure the opening, for sure the closing, for sure pulse, washing hands, linen, of course, privacy. We would use for a couple things, but I feel like for sure, I know she said it, I don't really care, but I know it's you need hand to hand care, you need dressing the patient, you need changing, I don't know, it's a little
Yes. Yeah.
because then you get a bunch of stuff checked out. When it's the skills
Yeah.
and the bodies. And then we can use it, just so that's something we have to practice with. I think
Right. Is it cold in here? Is it okay? Good. Okay. All right, any questions on what we've gone over so far? Any questions? All right, let's talk about foot care now. So this is our synopsis page for foot care. We've got our skills-specific principles we need to learn. We'll get to that. We have the overall principles that are going to apply to this skill. Nothing new to learn. We know to follow we know every skill starts with an opening. Every opening starts with a knock. We know to evaluate if we need gloves. We know to use a barrier. We know linen rules. We know washing rules. We know how to clean basins. And we know to do our closing. So there's really nothing much new to learn here. Okay. And foot care itself, super easy because it's a variation of hand and nail care. So if you look at the top of page 119, it gives us our care plan. It tells us to provide foot care for 1 foot using soap and water. The resident is sitting in a chair and the shoe and sock should be replaced at the end of the skill. That's it, 1 foot. So it looks a whole lot like hand and nail care. Remember, with hand and nail care, a patient was sitting in a chair. Foot care, a patient sitting in a chair. It's a live patient for both. With hand and nail care, we put the hand in the water to soak. Foot care, we'll put the foot in the water to soak. Hand and nail care, we took the hand out to wash it. Foot care, we'll take the foot out to wash it. Hand care, we put the hand back in to rinse. Foot care, we'll put the hand back in to rinse. It's very, very similar. The difference here is that with hand and nail care, we cleaned under the nails and filed the rough edges. For foot care, we aren't doing any of that. We don't do anything with nails. Nothing, other than look at them. But we do want to look at them because if they need to be trimmed or ground down or cleaned or whatever, we have to tell the nurse because the podiatrist or foot doctor comes into facilities every month. But the patient has to be on a list to be seen. So we do foot care, notice there's an issue, let the nurse know, the nurse puts the patient on the list. When the podiatrist comes in, they see the patient. If we don't do foot care, podiatrist will never see the patient. If we don't report any problems, the podiatrist will never see the patient. So it's important that we understand what we're doing here. But when we did hand and nail care, remember the whole purpose was to keep the nails at a manageable length so we never had to trim them. We're not doing anything with nails. So why are we doing foot care? Right? So the reason that we're doing hand and nail care, keep nails short, the reason we're doing foot care is to look at the foot. Different purpose behind it. Let me explain to you why. In order to understand this, we have to have a very, very brief conversation about diabetes. Guys, this really is about a 6th grade level. I'm not going to go into anything very complex. People do master's degrees in diabetes. It is that complex. We're not going anywhere near that.
This is just a very, very general overview and how diabetes is going to affect your patient so you can provide more effective care. Okay. So let's talk about the way that food is metabolized. So every cell in your body needs fuel to run, every cell. And the best fuel is sugar. Best fuel is sugar. Well, thankfully, the best source of sugar is carbs. Those are the things that taste good, right? So anybody give me an example of a carbohydrate? What's an example of a carbohydrate? Bread. Yeah, bread. Pizza crust. Yes. Rice. Potatoes. Flour. Anything made with flour. Sugar. Anything made with sugar. All of those things, all of those carbohydrates break down in the body into sugar. That sugar then enters the cell. The cell now has the energy it needs to perform its cell processes, whatever that cell is designed to do. And the system works very well. The problem is not with the sugar. It's not even with the carbs. Although in our society, carbs get a really bad rap, right? People tell you, avoid carbs, no carbs, cut back on carbs. We need carbs. Our body needs carbs to be able to function appropriately. The problem isn't with the carbs. The problem is with the excess carbs. So you need a certain amount of sugar. So what happens is your cells get hungry. They tell your brain throws out a craving, mac and cheese, large fry, Big Mac, whatever you're craving. You eat those carbs, they break down into sugar. Those sugar molecules go into the cells become happy, and now they're well fed. But anything that's not used by the cell becomes a problem because sugars are crystals, and crystals are heavy, and crystals can't be excreted by the body very effectively. It's very hard for our body to pee out excess sugar. You take in too much vitamin C? Nah, we gotcha. No problem. You're going to pee out what you don't need. You take in excess vitamin B1? No problem. We gotcha. You're going to pee out what you don't need. Take in excess sugar? Oh, we aren't peeing that out. Now we got to store it on board. So your body has storage units. We call them fat cells, but that's all they are. That's all your fat cells are, is a storage unit. And when you have too much sugar that's not being used by the cells, your body converts it into something called glycogen, which is nothing more than putting the sugar in a box, taping it up, and shoving it into a fat cell. Now, if you ever run out of sugar later, we can open that storage unit, get the box out, take the sugar out of the box, and you can use it. Okay, good. So sugar has to be used by the cells or it gets stored on board. But anybody ever watch those storage shows that are on TV every once in a while? Okay, a lot of times when you go to a storage unit that's been left, nobody paid on it. It's now being auctioned off, right? You never know what you're going to get when you open that door. And it could be shag rugs from the 70s that are completely out of style. Nobody's going to want this junk, right? That's what happens to glycogen over time. When we put the glycogen, the sugar in a box and put it in a fat cell as glycogen, it isn't effectively used after a long time. So now it's just kind of sitting there, getting all icky. Nobody wants it. It's not worth anything. So this is how we put on weight. Make sense? Starting to put it all together? So carbs are good as long as you use the carbs you eat. When you eat too many carbs that you're not using, then we store them. And that's okay as long as you're going to use them soon. But if they stick around for a long time in those storage units, yeah, we're not really going to use those. They're going to stay there. We're not going to get into that storage unit. And this is why losing weight becomes a problem, because it's very hard to burn old glycogen. Good? Make sense? Okay. All right. So you have this concept down, right? Cells get hungry. We eat carbs. Carbs break down into sugar. Sugar goes into the cells, feeds the cells. Anything excess gets stored in the body. Good. Okay. Now, the part of that process I did not tell you about was how that sugar gets into the cell, because the cell is actually locked. So when you eat carbs, those carbs break down into sugar, but your body has to produce a key to open the cell. That key is actually made inside your body by your pancreas. That key is actually called insulin. Insulin is a hormone. Remember I said that hormones are way more than just sex hormones, right? Insulin is a hormone, but it's designed, its one job is to open the cell so the sugar can go in. Good? Good. So this is how it works. Cells get hungry. They tell the brain eats, triggers a craving. You eat carbs, they break down into sugar. Or if there are no carbs, sometimes in extreme cases, your body will go into a storage unit and get that stored sugar. But remember, it's got to be pretty fresh. Okay. But we get sugar in the bloodstream. Your body then makes a key called insulin that will open the door and allow that sugar to go into the cell to be utilized. So this system breaks down if, number one, there's no sugar, or number two, there's no key. Good? Make sense? Remember, 6th grade. All right. So what ends up happening is if our body doesn't make insulin, doesn't make that key to open the door, our cells starve. They tell the brain, hey, I'm starving. The brain triggers a craving, usually carbs. And we eat carbs, and those carbs go into the bloodstream as sugar. But those sugar molecules just keep jumbling up. They can't ever get into the cells because there's no insulin. Good? So now we have hungry cells and lots of sugar, but the sugar can't get into the cells to feed them. What do you think happens to cells if they don't get food? They die. Absolutely. So that's a problem, isn't it? This is diabetes. This is diabetes. When we have a cell that's hungry, yelling at the brain, we're starving. We eat and get sugar. The sugar goes into the bloodstream. That's fine. But there's no way of getting that sugar into the cell. So now the cells are still starving. And the sugar is backing up in the bloodstream. So we quickly package it, as much of it up as we can, and put it into storage units. But at some point, we're going to run out of storage units. We're going to run out. There's nowhere to put this sugar. You can't pee it out. So what happens with it? Well, we end up with high blood sugar. You ever hear that term? High blood sugar? We call it diabetes. And what that tells us, if we got a lot of blood sugar, what that tells us is it's not able to get into the cells. Well, the only missing part here is the key. insulin. So when you have high blood sugar, we know your body is not producing insulin. And that's diabetes. Make sense? Okay. So why do we need to know this? Why do we care? Well, we care because how it's going to affect our patient. Remember, it's always about the patient. So on planet Earth, we have gravity. We talk a lot about gravity today. Today is Gravity Day. We have a lot of gravity. The problem with sugar is it's a crystal, similar similar to what you see here. This is a crystal. You see that? If you had to describe this crystal, how would you describe it? Give me a word. How would you describe it? Shiny? White? Clear? You guys see that? Sharp? Jagged? Prickly? Pretty? But we need to understand that this is what a sugar molecule looks like at a microscopic level. Sharp, prickly, solid, hard. Have you ever had a cake or a cupcake and you left it out on the counter for a day or two with frosting on it? That frosting breaks down and it becomes kind of grainy and a little oily, right? That is what is in your bloodstream when we have blood sugar that's not being used. They're crystals. Sugar is a crystal. Do you think that can be good at all? And that's what we're working with here with diabetics. We have excess sugar that's not being used by the cells, can't go in the fat cells, we can't store it. So it's just circulating. And they're hard, jagged crystals. But they're also a little bit sticky. And they're going to coat the inside of our arteries. That's going to keep our arteries from being able to expand and contract because it's hard and it's coating the surface. But because they're sharp, jagged things, they're going to catch everything that's floating by too. Things like cells. Things like cholesterol, which looks like pizza cheese in your arteries, actually. If you were to cut your artery open and look at the cholesterol, it looks just like pizza cheese. It's amazing. It'll put you off of pizza cheese for a while. So all of this stuff is going to get all tangled up inside these arteries. And it's going to make a big gooey mess. And let me show you what this looks like. So this is an artery of a brand new person, basically. Our arteries don't look like this for very long. But this is a nice artery. It's clean. All of its inner cells are there. No big gunk buildup. The artery can expand when it needs to, can contract when it needs to. Like if I'm bleeding out, I want my artery to be able to contract to close off that bleeding. If I need more blood flow, like I'm running from a bear, I need my artery to be able to expand to give my leg muscles more fuel to run away from the bear, right? I need it to be able to expand and contract. So this is a good artery. And it doesn't last very long. In America, our diet is not conducive to keeping our arteries like this. And what happens in a lot of cases as we age is you'll have patients in their 60s and 70s going, well, I never had diabetes before. I don't know why I caught it now. Why did it show up all of a sudden? I've been eating well. I'm eating salads. I'm doing everything right. Why did I get diabetes now? So let me explain to you why. Because diabetes does not start in your 60s and 70s. It starts when you're 2. So at 2, 2-year-olds get up, 5 o'clock in the morning, 5:30 in the morning. They are raring to go. Mom gets up, stumbles out to the couch and goes, oh, it is too early. Hands a kid a Pop-Tart. Pop-Tart are carbs. So the kid eats a Pop-Tart. It breaks down into sugar. That sugar goes into the bloodstream. Insulin gets, go back one. Insulin gets produced. The sugar goes into the cell. Cell's happy. Everybody's fine. Mom gets up about 6:37, gives the child a bowl of cereal. Now, kids aren't eating all bran, are they? What do they eat? Yeah. Honey Smacks, Fruity Pebbles, Captain Crunch, all the good stuff, right? Those are all carbs. Those carbs break down into sugar. The pancreas has to produce insulin to get them into the cell. Mid-morning snack, probably some fruit or something like that, because mom's a good mom, gives the child strawberries and blueberries, and that's great, but those are all sugar. Different kind of sugar. It's fructose rather than glucose, but it's still an ose. And ose needs insulin. So we ate berries. Our pancreas produced insulin to get the glucose into the cell. Cell's happy. Lunchtime, national toddler diet of chicken nuggets and mac and cheese, which are carbs. So those carbs make the body produce insulin to get the sugar into the cell. Cells are happy. Afternoon snack, Little Debbie something, right? That's all sugar. So that means that the body has to produce insulin to get that sugar into the cells. Dinner, spaghetti and broccoli. Kid's not going to eat the broccoli. He's going to eat the buttered spaghetti, which is a carb, making the body produce insulin to get those sugar molecules into the cells. And then, of course, we don't send children to bed without dessert. Cookie, ice cream, something that's going to break down into sugar and make the body produce insulin. So that child grows up, gets to be a teenager, lives off of French fries and pizza, and this whole system just ramps up a little bit more. The pancreas has to produce a whole lot of insulin to keep up with our dietary needs. By the time we get to 60, our pancreas is like, I'm done. Done. I'm not doing this anymore. You have overused me for 60 years. I'm out. And this is how a lot of our older individuals are developing diabetes in their later years, even though they're now adopting better dietary habits. They've still overused their pancreas. Make sense? So what does that mean for us? Well, if we have all of this, all these sugar molecules that we're not letting into the cells because we're not making insulin, and our fat cells are already overly full and they're just circulating, our arteries go from this to something like this, which doesn't look very bad, does it? But if you look close, you'll see the diameter has decreased. Okay, this one's a little narrower than this one. Do you guys see that? Just a little bit, not much, just a little bit. That means the pressure inside of this one is going to be higher. What flows through here? It's an artery. What flows through there? Blood. High blood pressure because our arteries are smaller. Now, if we don't pay attention to that, this usually shows up in your 20s or 30s. Blood pressure just ticks up a little bit. Doc says, hey, you better watch what you're eating. We got some warning signs, but we don't, because French fries are good, right? So if we don't pay attention, then we end up with something like this. This happens in your 30s, 40s, early 50s. This is a warning sign. If you look, we are significantly smaller. Now, it's not just the fact that we're smaller, it's the fact that we can't expand and contract anymore. It's also the fact that all of this is cholesterol, sticky, like pizza cheese. Cell fragments, well, that means those cells can't do their job. Platelets, which are what stop you from bleeding. Enzymes, hormones, like all the things we need, and it's all trapped in here. But if you remember, I said last class, and anytime blood slows down or stops, it tends to clot. Okay? So if we have this and blood is slowing down, by the time we get to this, we're in real trouble. We now are at risk of having blood clots. How much healthy blood can get through there? Very little. Very little. Do you see how this is a problem? This is advanced diabetes. Not much good blood is getting anywhere. So our patient's tired all the time. They're not healing well. They're not getting the nutrients to the areas that need it. Good? Actually, it's not good, but all right. So what does gravity have to do with this? Well, sugar is a crystal, heavy. Gravity pulls everything heavy down. What's the lowest part of my lower body? What's the lowest part of my upper body? Hands. That means that all of these sugar molecules are going to be pulled down to my feet and my hands. Hand care, foot care. We're going to see the effects of diabetes in the hands and the feet first. The vessels are smaller. Gravity's pulling those crystals down. So when you're doing hand care and you're doing foot care, our real purpose here is to look for anything that is out of place. Any red areas, any wounds that aren't healing, any sores, anything. Now, hands are pretty visible. They're out here in the open. People see them all the time. We eat with them. We do all kinds of things with our hands. We notice pretty quick when something's going on with our hands. But feet, on the other hand, they're usually covered with socks and shoes. They're very rarely out in the open. And one of the effects of aging is we get less bendy. So you might be able to look at the bottom of your feet now. You get a little older, you're not going to be able to see the bottom of your feet very well anymore. And that's because we get less bendy. So that's what foot care is all about. It's looking at the foot. It's having an excuse to look at the foot to see if there's anything there that might need to be addressed, because your patient may not know about it. But it gets worse than that. This is bad enough. This is definitely bad enough. But it gets worse because all of these sugar molecules coat your nerves too. Again, hands and feet are going to be affected more, but it's just like having a power line in the ice, in a blizzard, in an ice storm. You know how the ice will coat the power lines and then the power has a hard time getting through? That's what happens in your nervous system. All these sugar molecules coat these nerves, and now if you stub that toe, that signal, the toe knows you stubbed it, but that signal is going to have a really hard time getting all the way to the brain. So you may have an injury on your foot that your brain is absolutely not aware of. Good? Make sense? So let me tell you a story about why this might be important. We're going to talk about Henry, real life story. It's really happened. I was a agency nurse. An agency nurse is like a substitute nurse. You know, in school you have a substitute teacher when your teacher can't be there. Well, an agency nurse doesn't work for the facility. They get sent in to cover for a nurse that isn't there. Okay. So not my facility, not my patients. Don't know anything about any of them. And I was on the rehab side and got my report, went in to do my assessments. And I walked into one room and the light in the room was off. He had one small light above his bed, just one of those small fluorescent lights. That's all that was on. So I got to do an assessment. I walk in, I flip on the light. He starts yelling right away, turn it off, turn it off, turn the light off. Okay. So I turned the light off and I approached the bed and I said, hey, Henry, my name is Patty. I'm your nurse today. Is there a reason we don't want the light on? Something going on? Do you have a headache or something? Assessment, right? I got to find out what I'm working with. He says, no, I have diabetic retinopathy and the bright lights really hurt my eyes. I said, okay, no worries. But I got to do a quick assessment. I've got his cup of pills there. I'm having a conversation with him to figure out what I'm working with here. And as I'm standing there, I'm catching an odor. Now, if you've ever smelled a wound, they're very distinctive. And when there's a wound, you know there's a wound. So I'm like talking to him, pull my report sheet out of my pocket. As I'm talking, I'm looking at the report sheet. There's absolutely nothing on there about a wound, wound care, wound assessment, nothing. That's a problem. So I tell him, hey, Henry, and he's a really gruff guy. He was like ex-military. He was really rough around the edges, had no social skills, right? He's just barking. And so I said, hey, Henry, I need to take a look because I think you've got a wound brewing somewhere and I need to see what we're working with. Can I look at your skin? He says, do what you got to do. So I turned him over, looked at all the usual suspects. Remember that slide we saw just a little bit ago, right? All of our pressure points, the back of the head, the shoulders, the lower back, the hips, the buttocks area, the back of the thighs, back of the calves, and down to the heel. I'm not seeing anything, but when I get to his feet, he's got those slipper socks on. You know, the kind with the little white dots on the bottom? So I said to him, hey, Henry, can I take your socks off real quick and take a peek at your feet? And he immediately barked, no. Okay, red flag. I know where my problem is now. So I asked him why. And he said, I've got neuropathy. And if you touch my feet, it really hurts. I don't like anybody messing with my feet. Leave my feet alone. So I turned up the charm because you can always get further with people by being nice than being mean. So I turned up the charm, and it's really hard to deny me when I get charming. And I got him to finally agree. I took the right sock off and the foot was a little flaky, definitely needed some lotion, but it was okay. Tried to take the left sock off and it was stuck to the bottom of his foot. Found it. Found my problem. Now, what I want to point out here is if he told me no about looking at his feet, what do you think he told the CNAs? No, we don't have any clue how long this guy had gone with nobody looking at his feet. We have no clue because the CNAs never reported it to the nurses. So we don't know. But I go get a basin of salt water. We call it normal saline. And I put the whole foot, sock and all, in the water to loosen it up so I can figure out what I'm dealing with. I got to get it uncovered. And I took my gloves off. I washed my hands, went to take care of some other patients, came back 20 minutes later, took his foot out of the basin. And I went to take the sock off. And I had to give a little bit of pressure because it was really stuck on his foot, even after soaking. So I kind of give a little pressure to get it up, and something went flying past my head when I did that. Sock came off. I'm counting toes. 1, 2, 3, 4, 5. They're all there. Good. Yay. That's a good day. So what went flying past my head? I look on the floor, and it was a floor like this, speckled. Baseboards were like this. And it took me a minute to find it because it kind of blended in. But what I found was this. This is a white painted metal thumbtack that had been lodged in his foot through the sock, and we have no idea how long it had been there. Now, he didn't know that the thumbtack was there because of this. He couldn't feel it. The nerves had been corroded. So I looked at the bottom of his foot, and he's got an area about this big around, hard, black, dead tissue. Now, we're good in medicine. We can heal a lot of things. We've got a lot of tricks in our magic bag. But what we can't heal is dead. Dead is dead. We can't do anything about it. So I know this guy has got a long road ahead of him, and it's not going to be pleasant. And I was really sad for him because he was only in his 50s. That's young. So I called the doctor. I called the family. I called the wound care specialist. I did the wound care. I took my pictures. I documented everything, and then I left. Not my facility, not my patient. But Henry stayed on my mind for a while. And it was months later, probably about 9 months later, although I'm not real sure of the time frame, but months later, I got assigned back to that facility. But this time I was on the long-term care side. But as I drove up, I'm thinking, I wonder if anybody has an update on Henry. I'd like to know how he did. So I walk in, I go get report. And before I could ask somebody, hey, do you know about the young guy? Because he was young. I'm getting a report, and Henry's name is on my sheet. So he had been transferred from the rehab side to the long-term care side. This is where he now lives in his 50s. Lives. Not staying for treatment. Lives. That was heartbreaking. So I went in and I said, hey, Henry, I'm Patty. I'm the nurse that found the wound on your foot. How are you doing? He pulled the sheet aside, and he had to have a below-the-knee amputation. He lost his leg. Now, to me, that is absolutely tragic. What makes it even more tragic is it was 100% preventable. Because if he had had shoes on, where would the thumbtack be? We don't amputate shoes. When we are working with diabetic patients, you should never, ever walk them without shoes. Because they may not be aware, because of this, they may not be aware of any injuries they incur. Do you guys get that? That is a real story. And the really sad thing is this guy passed away about 2 years later because of infection. They couldn't get the amputation to heal properly because of diabetes. Remember, if you don't have big blood vessels and they're all gunked up, we're not going to get good healing blood to the areas that need it. This is bad. But what makes it even worse, okay, it's 100% preventable. If he had had shoes on, he wouldn't have had the thumbtack in his foot. That's bad. But what's even worse is the fact that the CNAs decided, for whatever reason, not to report any of this to the nurse. If we had known about it early, we might have given this guy a fighting chance. Do you see why I'm telling you half of your job is observation and reporting? And it's actually the more important half of your job. Taking a patient to the bathroom when they need to go, yeah, that's important. Absolutely. But recognizing the problems that they're having while they're in there and reporting those, way more important. Good? Does that make sense? Okay. That was over 20 years ago. 20 years ago. And I still remember him. I remember him because it was sad. We can do better than that. But this is why I teach the way I do. Because I don't want another Henry. I need to create mini me's out there that understand the importance of what I'm telling you so that we don't have any more Henrys. Now, this guy had no family to take care of him, which is why he ended up on long-term care. He didn't have anybody at home to help him out. And, you know, he probably didn't have anybody to care that he passed away. But that doesn't erase our need to care. Okay? Good? All right. So because of everything I just told you, we have a rule. This is the last rule that we have to learn. Pretty cool. You've learned them all. You've learned them all. So our last rule is shoe rules. So shoe rules boil down to if a patient's feet hit the floor, we talk about their shoes. Okay, if the patient's feet hit the floor, we talk about their shoes. People should never be walking around in bare feet or slipper socks. Now, we do have thumbtacks in clinical settings. We do use them all the time. But we use other sharp objects in clinical settings in healthcare. What kind of other sharp objects do we have? Needles, absolutely. Absolutely. We also have lancets, we have glass vials, we have fancy things like trocars. We have all kinds of sharp objects in healthcare. All kinds. Is it possible that one or more of those sharp objects might drop on the floor unnoticed? Would you let a toddler walk in a clinical setting barefoot? If you would not let a toddler walk in a place barefoot, you should never let a patient do it. Okay? Good? Really important. But there's another reason here that you probably haven't thought of. So I'm going to ask you one more time, how many of you guys have ever been a patient at a hospital? Oh, you're not going to like me after this. When you're a patient at a hospital, you go in, they give you a patient gown and a pair of slipper socks. You put them on and you crawl into bed because you're in the hospital. That's what you're supposed to wear. And at some point, you're probably going to have to go pee. So you get out of bed and you walk to the bathroom in those slipper socks and you do what you need to do in the bathroom and you walk back into bed and you get back into bed with those slipper socks. What did you walk through? Pathogens everywhere. Lots and lots of pathogens. Because what I didn't tell you is this lady over here, she had a hip replacement. This is your roommate. And after her hip replacement, she ended up with an infection. So we put her on IV antibiotics. Don't worry about it. We'll get the infection cleaned up. It's okay. We can treat it. But those IV antibiotics are pretty strong because it's a bone infection and they cause diarrhea. So when she tried to get out of bed onto the bedside commode, she didn't quite make it. So what's all over the floor? Yeah, diarrhea, absolutely. Now, housekeeping does a great job. No shade on housekeeping. However, some of those pathogens are going to remain, and you're walking right through them. And you are going to take those pathogens right into bed with you. In a clinical setting, that floor is not clean. Healthcare workers walk through all sorts of environments, home, Publix, parking lots, clinical settings with those same shoes and then walk on that floor. So even though housekeeping did a stellar job, you are bringing pathogens in from the outside on your shoes. Now, you let your patients walk around in slipper socks in that environment and climb into bed with them. It's just like you wearing your shoes to bed. Pretty gross. Slipper socks are not enough. Patients should have shoes on when they walk for injury prevention, but also for infection control. Now, most of the time, they have shoes. Very few people go to the hospital without shoes. If they can walk, they usually have shoes. They may be in a bag in the bottom of a closet, but they're there. Go find them. Make them available for your patients. Help them put them on and take them off. But don't tell them, oh, just walk around in your socks. It's fine. It's not fine. Now, if your patient doesn't have shoes, if they came in an ambulance and there are no shoes, then let the nurse know, because we have social workers. Social workers' job is to contact the facility and get George his shoes. Or if George is homeless and has no shoes, here's a gift card for George to get shoes. Or we can call the family, bring George's shoe. We've got resources. We've got phones. We've got social workers. What we need is a CNA that's observant. Good? So I want you to think back to your last hospital stay and think about all the things that you potentially walked through that climbed into bed with you. And tell me you're not grossed out. Even more intriguing, I love this, right? If you go down the road this way to our local hospital, I will not say names and neither will you. There's a Subway in the lobby. Good subs. When I worked there, it was great for lunch. But do you know what was always in the line when I went into the lobby to get a sub, when I was working there? There was always a patient in the line with a patient gown on, another one on backwards like a robe and slipper socks. They walked all over that facility in those slipper socks and then right into bed. Again, a little bit of knowledge can actually be dangerous if it's not applied correctly. Slipper socks, good idea, helps prevent slips, but it is not a suit of armor. Okay? The next point on there, we're going to, or the rest of the points we're going to get to on Monday. So this is just an introduction to shoe rules. We'll finish it up on Monday. But the two I want you to remember right now are if the patient's feet hit the floor, we talk about their shoes, and slipper socks are not enough. So if you go back and look at this care plan, it tells us patient will be sitting in a chair at the side of the bed, perform foot care to 1 foot, and their sock and shoe should be replaced at the end of the skill. This is why. Because they don't want you to end the skill with a bare foot or just a sock on. If you look at the bottom of the page before, you'll see test-specific information. It tells you that somebody with for the test, somebody like you is going to be the patient. So you might be the patient for foot care. You might be a patient for foot care. I know it's not comfortable. I get it. I don't like people messing with my feet. I am super ticklish. I don't get pedicures because I spend the entire time pulling my foot away and laughing hysterically. I sound like a lunatic. I understand. But for the test, you're just going to grin and bear it. Okay, good. Makes sense? All right, well, if you're the patient, you're not taking, when you go to test, you're not taking an extra pair of socks with you in your back pocket. Nobody told you to bring extra socks, right? So you're just there with whatever's on your body. So in a clinical setting, if we do foot care, we're putting clean socks on. Clean feet need clean socks. I mean, that makes sense. But for the test, there are no clean socks. So that's why our care plan tells us to replace the sock and shoe because it's specific to that testing environment. Good? Make sense? All right, so if a patient's feet hit the floor, we have to talk about it. That means that for the test, we want to say, I'm going to put your shoes on, or you need shoes at the end of this. You have to somehow acknowledge that you know slipper socks aren't enough. Remember, they don't protect against injuries and pathogens. Icky, icky. So let's figure out all the steps of foot care. So the first thing we're going to do is our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do foot care. Is that okay? Close curtain, wash hands. Now we need a barrier. So I'm going to put the barrier on the floor, not on the table, because my patient can't like take their foot off and put it in the basin. It's got to be on the floor. So this table, not a part of this skill. Barrier goes on the floor. I'm going to go get the rest of my supplies, put those on the barrier, and now I need water. So washing rules. I'm going to get my basin, take it over to the sink, and I'm going to turn the water on with a paper towel. I'm going to check the water. How should it feel to me? Warm. Who else checks it? Patient. So I'll get some water, bring it over, ask them to check it, and then I'm going to have them put their foot in the basin. Now I have to get on the floor. So if you want to put another chucks down on the floor because you know it's not clean, that's fine. You can do that. Put a towel down on the floor, put a towel. I don't care what you put on the floor. Whatever you want is fine. But you can also kneel on the floor with your uniform. That's fine too, because once we start work, is our uniform clean? No. So we're already acting like it's not clean. It's fine. Good? You guys understand that principle? All right. So we're going to put the foot in the basin to soak it, take it out, rest it on a towel, just like with a hand, to wash it. Put it back in the basin to rinse, take it out, rest it on the towel to dry it. But the whole time we're doing that, we should be looking at the foot. That's the whole reason you're there. It's not to wash the foot. It's to look. It's to have an excuse to look. Okay? So you want to look at all areas, the top, the bottom, the front, the back, everything. If you notice something, go get the nurse before you put the shoe and sock back on. Because there's nothing worse as a nurse for you to come tell me, hey, Mr. McGillicuddy has a red area on the bottom of his foot. And I say, okay, where is he? Oh, he's in the activity room. How am I supposed to look at it when he's in the activity room with a shoe and sock on it? So I'm going to tell you, go get him, take him back to his room, take a shoe and sock off, and let me know when he's ready. So if you just stop, go and get the nurse. Hey, I'm doing foot care on Mr. McGillicuddy. He's got a red area. Do you want to come see it before I get him buttoned up? Yeah, hold on. Let me go with you. I can take a 2-second look, see what I'm working with, and then call the doctor, call the wound care specialist, get whatever orders I need to get. Work with your nurse. Good? Questions? All right. So the whole purpose here is to look. But if you remember glove rules, I said if you're going to touch body fluids, personal skin, or non-intact skin, you need gloves. But I also said if you might touch body fluids, personal skin, or non-intact skin. If the whole reason we're doing foot care is to look, that means we don't know. If we don't know, that's a might. If it's a might, do we need gloves? So to do foot care, you should wear gloves because we don't know if there is a wound. Good? Do you guys understand how to put all that together? Okay. So all the linen rules apply, right? All the linen rules apply. You don't want to take too many. If you take too many, you got to put them in dirty linen. Don't hold them against your uniform. You know, don't snap them and shake them. All those same linen rules apply. that we've learned up till now. So this really isn't a hard skill to do. You're going to put the foot in the basin, take it out to wash it. Put it back in to rinse, take it out to dry. Look at all surfaces. We're going to apply lotion. That means we warm it up first and then we put it on. What do we do after? Wipe it off. I don't want you to put lotion between the toes because between the toes is already warm and dark. When you put lotion there, it holds in moisture. So now we got warm, dark, moist, which is pathogen central. So athlete's foot really is what we're worried about here, a fungal infection. So no lotion between the toes, but everywhere else is good. Okay. All right. When we put the sock on, we want to remove wrinkles. That has everything to do with what we talked about earlier with wrinkles. You see how we're building? We learn something and then we build on it. And then we learn a little bit more and we apply it somewhere else. That's why this program works, because I'm not just telling you something once, I'm telling it to you different ways to make it all stick together. Okay, it does work. All right, no bare feet on the floor. That's self-explanatory. And then we'll apply the shoe and secure it over the sock. So here's your step-by-step instructions. There's 32 steps for this one. Again, easier than a peanut butter and jelly sandwich. Takes a little longer though. A lot of supplies for this one. Make sure you're learning your supplies. And remember that if you come in here and practice, you have the supplies available to you. You've got everything you need to practice, right? Washcloths, towels, basins, soap, lotion, everything is here. But if you're not practicing here, you might want to consider buying a practice kit from us. The practice kits have everything you need to be able to practice at home. And that's something that I've been working on this week. I'm redoing the practice kits. We're actually adding new items to it. So, and I'm not increasing the price. So we're adding a bath blanket in there. We're adding stuff for PPE, personal protective equipment, putting on and taking off. We'll talk about that a little later. I'm adding some extra stuff in there and little care plan cards. So all kinds of stuff to help you guys practice. So it's definitely worth it if you can't come in here and practice. But if you can, you have the care plan cards. You have all the supplies. All you need is another student to practice on. So make a friend. All right. So let's go ahead and show you this skill. I am not getting on the floor because we all know why. So let me show you this video. I'm getting ready to retape the videos, and this is the one I'm dreading because I don't know if I can get off the floor. We'll see what happens. I think it's going to have to be the magic of Hollywood. CGI. Although I started making, I have another side business we're just developing and making pain relief lotions and bath products. And I've been using the formula I created. And it is actually having an effect. If you go back and watch last session, the videos from last session and these, you can actually see the difference in how I'm moving. So it's actually effective. It's amazing. So that business is not quite off the ground yet, but it'll be amazing when it is. All right, so real quick, there is a question. For some reason, if the person forgets to take a shoe off for the skill, should I first take the shoe off and then go wash my hands? For the test, the evaluator sets the scene. So the evaluator will ask the person, can you sit in the chair, take a shoe and sock off, and just place it right beside you. So their shoe and sock should already be off. But we can't ever touch the patient until our hands are clean. Please remember that.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
Wonderful. I need to do foot care. Is that okay?
Yes.
Let me go close your curtain, wash my hands, and then I'll gather your supplies.
Okay.
Okay, I'm going to get a barrier, and we'll place this on the floor right in front of you, and you can place your foot on the barrier. I'm going to get a basin, soap, and lotion. We'll place that on the barrier. I'm going to get 2 washcloths and a towel and a set of gloves. I'm going to get some water for washing. Okay, Mr. Jones, would you like to check the water temperature and make sure it's okay?
Yes.
Is it
Great.
good?
Yes, great.
Very good. I'm going to set this here. And I'm going to kneel on the barrier and apply my gloves. I'm going to roll up your pants leg and lift your foot so I can remove your sock. We'll place your foot in the basin to soak. I'll take the first washcloth and wring it out, making sure that your foot is wet. I'm going to place your foot over here on the towel and apply soap to the washcloth. You want to wash all surfaces of the foot. I'm going to lift your foot up so I can wash the bottom, and I'll observe for any red areas, wounds, sores, or any other abnormalities. We'll put your foot back in the basin to rinse. Okay, I'm going to place your foot on the towel to dry. And I'll ensure all surfaces have been dried thoroughly. I'll take one of the narrow edges and go between your toes to blot. And I'll dry the bottom of your foot. Now I'm going to apply some lotion. We'll warm the lotion in our hands and apply lotion to all surfaces except between the toes. So I'm going to lift your foot and we'll apply lotion to the bottom as well as the top. And now I'm going to wipe off the excess lotion so that you don't slip. Okay, go ahead and place your foot back on the barrier. And now I can reapply your sock. Okay. And we'll put your shoe back on. Can you slide your foot in there for me, please? Okay, Mr. Jones, I need to put all of my supplies away now. I'm going to gather my dirty linen and place it in the dirty linen hamper. I'm going to take the basin to the sink and clean according to the basin cleaning procedure. On the way back, I'll collect the soap and the lotion and put the basin back in the drawer. Now I'll collect the barrier and throw it away. Now I can remove my gloves. Okay, Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is here. If you should need anything at all, please let me know. Can I get you a magazine while you're waiting?
No, thank you.
I'm going to open my curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done.
Okay. Any questions on that one? As long as you remember, it's very, very similar to hand and nail care. All of those same principles that we've learned apply. So there's not really much to learn here other than understanding diabetes and why we're doing foot care. That's the real big thing that I need you to understand. But the skill itself, pretty easy. Just follow all the principles that we've learned. Do it on one hand, like the care plan said. Make sure you say something about understanding why we're doing foot care. I'm looking at the foot. So the evaluator knows that. And that's what this lecture was all about. Then the skill itself is pretty easy. Getting off the floor, hardest part. All right, so now we're going to move on to mouth care. Mouth care. Not much to teach you on mouth care, guys. You already know how to brush teeth. You wet the toothbrush, put some toothpaste on it. You clean all areas, top, bottom, front, back, tongue. Let them rinse and spit. Clean them up after. Make sure they're nice and dry. And then clean your basin like we clean everything else. Patient does need to be in a sitting position for this skill. That just makes sense. You don't want to choke them. And we want to put a towel over their clothing just to protect it when we're working with toothpaste because they're sitting up. They're not standing over a sink. So there's not much to teach you with this particular skill. You already know all the mechanics of it with everything that you do for yourselves and everything we've already talked about. So not a whole lot to learn here. The principles that are involved, of course, we're going to follow the care plan. We're going to do our opening. We're going to use a barrier. We do need to use gloves for this because we are working with body fluids, certainly. Linen rules apply because we're working with a towel, right? So you don't want to hold it against your uniform. You don't want to snap it or shake it. If you take too many, you're going to put it back in the dirty linen, all of that. Basin cleaning, we know how to clean basins. Just rinse them, dry them, and store them using a paper towel. And we know how to do the closing. So all we need to learn here is the skill-specific steps. Okay? No new principles to learn. So if you go to page 93, at the top of the page, you'll see the care plan. It says a resident with natural teeth is lying in bed and needs mouth care. The resident is not able to perform their own mouth care. That's it. You just brush their teeth. So safety first, your patient is lying in bed, so we're going to get that head of the bed up. When I say up, I mean up, all the way up. I don't mean a little way up, I mean up. At the end of the skill, it's whatever they want. If they want to stay up, that's fine. If they want to lay down, we can do that too. However they want it at the end, but not for the skill. Skill up is as far up as we can go. So remember that laying down is not a safe position for mouth care. If we don't elevate the head of the bed, the patient can aspirate. Aspirate is the technical term for breathing liquid into the lungs. We don't want our patient to aspirate. You do need to know that term. They're not going to ask you what is aspirate, but it might be on the exam, like on the written test, like to prevent aspiration in a patient who is lying in bed, what is an essential step when performing mouth care? If you don't know what aspiration is, it's hard to answer that question. Good? All right. So you can see on step 7, we're going to get our patient in a full sitting position. Now, I'm going to tell you this is one time where my video is going to be a little different than what I'm teaching you. So I am going to show you the video for this, but it is a little bit different, and let me explain why. Back in 2016, when I did these videos, they let us put the head of the bed up before we washed our hands. But now they got that checkpoint that says must have clean hands to touch the patient. So now we're going to do our opening. We're going to wash our hands, and then we're going to put the head of the bed up. But I don't want to touch that controller because the controller is not clean. So I'm going to get a paper towel and use it as a barrier between my hand and the controller. That is in your book. So if there's a discrepancy between the video and your book, you're always going to go by your book. The book has been updated. The video, I'm still working on. Okay. Dignity is important. We're going to use a towel over the patient's chest to protect their clothing. And we want to wet the toothbrush before we put toothpaste on, just like we did with our hands, right? When we're washing hands, we're going to wet our hands and then put soap on so the soap spreads around evenly. With a toothbrush, you want to wet the toothbrush before you put the toothpaste on so the toothpaste spreads evenly. It doesn't just glop in one area. We're going to brush the top, the bottom, the front, the back, and the tongue. Whatever they got, we're going to brush it. And then we're going to let them rinse and spit. Guys, just use a little bit of toothpaste, just a little bit, because otherwise they're going to be rinsing for like 20 minutes. Use like a whole big stripe of toothpaste, they're going to be rinsing forever. Remember, they're not over a sink. So a little bit of toothpaste is all we need here. After we allow them to rinse as much as they need to, then we're going to dry their mouth off and clean our equipment and put it away, throw all of our disposables away, and do our closing to end the skill. So a common question I get asked is, am I going to have to brush everybody's teeth? Because this is just like really awkward. It is awkward to have somebody brush your teeth, for sure. It's awkward. I don't even like people in the room when I'm brushing my teeth because I'm like this big drippy mess. I mean, to me, it's kind of a private thing, right? I mean, if you walk in, I'm okay with it, but I'm not going to go out of my way to brush my teeth in front of other people. Your patients kind of feel that way too. If they can brush their own teeth, trust me, they're going to want to. They're not going to want you in their mouth unless they have to. How many people are like super excited to go to the dentist? It's usually on the top 10 things of list of things I don't want to do. Well, mouth care is kind of part of that as well. If the patient can brush their own teeth, they will. They aren't going to want you in there. So how do we know when we should be brushing teeth and when the patient's going to do it? Care plan, absolutely. Easy answer. So no, you're not going to brush everybody's teeth. But if you need to brush somebody's, if they can't do their own, please do a good job. I've got a story for this too. This is horrible, horrible. So I was working in a step-down unit in a hospital. It's like intermediary, like when you get out of the ICU, there's a step-down unit. It's a little bit more monitored before you go before you get discharged out or go to a regular floor, med-surg floor. And we had a young guy come in. He was in his late teens, early 20s. I can't remember exactly how, but he was young. I mean, crazy young. And he had been riding a motorcycle recklessly without a helmet. He was ejected, got into a problem, was ejected, and flew. I don't even know how far. It hit his head. So he had a closed head injury. He also broke his neck at the time. So he was paralyzed. Actually, it was kind of like from here down, like mid-chest level down, he was paralyzed. So he could move his shoulders, but had very, very little ability to control his upper extremities. He had nothing chest down, no motion at all. So this guy had been in the ICU for like weeks, trying to get him stabilized and go through all the testing and figure out what was happening with him. And then we get him in the step-down unit before he's going to go to a nursing home for long-term care. because his family couldn't take care of him. They all worked. There's nobody home to take care of him. So we get him, and I noticed that he's not talking a whole lot. In fact, when I'd ask him a question, he'd always turn his head to the side to answer. And I thought, it's probably depression. I mean, this guy has gone through some pretty, gnarly life changes. He can't work. He's paralyzed. I mean, this is bad. This is life-changing stuff, right? So he's probably pretty depressed. And I'm thinking about getting a psych consult on him and just kind of working out how we can best help him. But then I started thinking a little bit more. And I asked him, is there a reason you're not looking at me when you're talking to me? Are you okay? Is everything all right? And he says, yeah, I'm just embarrassed. Embarrassed? For what? I mean, we're doing everything for this guy, right? Embarrassed for what? He said, well, I haven't brushed my teeth since before the accident, and I really can't brush my teeth because I can't really move well, and I know my breath is bad. Excuse me? You've been in the ICU for weeks and nobody has brushed your teeth? He says, no, I didn't know they did that. Yeah. If you can't brush them, somebody has to brush them. So it turns out nobody had ever really looked. Nobody knew what was going on in there. So, of course, we get a dental consult, and now we're looking, and he actually had to have multiple teeth removed because nobody had brushed his teeth. That's horrible. It's bad enough that, there was something else that happened to this guy too. Hold on. It's bad enough that you're in this traumatic, life-changing accident and that you're paralyzed. It's even worse that you can't even go home. Right? And on top of that, we're going to neglect you and not take care of your most basic needs. We're not doing our jobs here. There's a problem here. So let me tell you the other thing that was neglected on this guy. He still had glass fragments from when the windshield that he hit shattered. He's had glass fragments. They hadn't picked all the glass out of his hair. So was anybody washing his hair? Now, I don't know about you, but I can't go weeks without washing my hair without feeling like a disgusting mess. So were we really helping this guy? No. We can do better. If your patient can't brush their teeth, somewhere along the line, somebody probably should have mentioned, hey, he's not brushing his teeth, clearly, and it's not on the care plan, so do you think maybe we should be brushing his teeth? Now, the nurses were all pretty concerned with, his blood pressure and his intracranial bleed and all the things he had going on. They're kind of concerned with the life-saving part of his care, right? But there were CNAs there. So should the CNAs maybe have recognized this as a need that's not being met? And could they have said something to the nurse like, hey, there's nothing on the care plan about mouth care, right? Maybe we don't want to do mouth care. Maybe he's got some serious lacerations in there. Maybe his jaw was broken. I don't know. But it's something that should have been brought up. Remember, observation and reporting. The nurses aren't going to catch everything. They are not going to have 100% accurate, perfect care plans all the time. They're human. But you guys are the next level of defense there. Good? Questions? Yeah, that guy is really stuck with me too. I feel really bad for him. That's a horrible thing. And anytime I see somebody flying down the road on a motorcycle without a helmet, I'm like, oh, don't do that. Don't do that. I don't want you to be in the same position. It happens quicker than you think. All right, so page 93 gives us our step-by-step instructions as well as our care plan. let me show you this video.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to do mouth care. Is that okay?
Yes.
Okay, I'm going to put the head of your bed up. And then I'll close the curtain, wash my hands, and gather my supplies.
Okay.
We'll get you to a full upright sitting position for safety.
Remember, you'll be doing
And
that.
if I can get you to lean forward, please. There you go. Is that more comfortable?
Yes, much.
Okay, I'm going to close your curtain and wash my hands now. I'll gather my supplies. I'm going to start with a barrier, and we'll place that on your overbed table. I'm going to get a towel, a set of gloves, a basin, toothbrush and toothpaste, and a cup of water. We'll prepare the toothbrush first. We'll get it wet, place a little bit of toothpaste on it, and set it in the basin. Mr. Jones, can I place this towel over your chest?
Yes, please.
Okay. And now I'll apply my gloves. Okay, Mr. Jones, can you open wide for me? I'm going to brush the back on the bottom. The back on the top. And can you bring your teeth together? And stick your tongue out for me. Thank you. Set that aside. Go ahead and take a sip. Rinse your mouth. Let me wipe that off for you. Another sip.
No, thank you.
Okay. Now I'm going to dispose of my cup, wrapper, and toothbrush. I'll be right back. I'm going to remove the towel and place it into dirty linen. Going to go clean the basin, and I'll be right back. I'll place the toothpaste in the basin, use the paper towel to open the drawer, and place the basin and toothpaste in the drawer. I'll clean up my work environment and go throw these items away. Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No,
A
thank you.
magazine?
No, thank you.
Okay, your call light is right here. If you should have any needs, let me know. Can I adjust the head of the bed for you?
No, this is great.
Okay, I'm going to open the curtain and go wash my hands. After washing my hands, I'll think about my skill, make any corrections I need to make, and then tell the evaluator my skill is done.
Okay, so Faith asks, is it proper to use the resident sink as a basin? For me, that's so gross and it's a no-no. So it depends on what we're talking about here, right? So you can't take the sink over to the patient. So if we're talking about using the sink to hold water while the patient is in front of it for bathing, that's fine. There's no problem with that. I would probably rinse it out first, but it's, the patient, it's their sink. They're there, just like you would. But sinks don't go next to a bed. They're not portable. So what we're talking about when we're talking about basins, we're talking about a portable source to hold water. So yeah, the sink really wouldn't be used in that manner. Okay. Me personally, if I'm going to use the sink to hold water, I'm going to wash it out first. But you're not going to need any of that for the state exam. Basins are portable things that hold water. Okay. All right, so the last skill that we have today is respirations. And we're going to get through this really, really, really quickly because we still have to go through the state test registration instructions. So really quickly, respirations, nothing new to learn. We know to follow the care plan. We know to do the opening. We know to evaluate if we need gloves. We know to do the closing. Nothing new to learn other than skill specific. So let's talk about skill specific. Your care plan at the top of page 55 tells us patient will be lying in bed for the skill. Count the patient's respirations for 1 full minute and record your readings. That's it. 1 full minute and record your readings. So how long are we counting for? Normal for respirations is between 12 and 20. So when you're counting somebody's respirations, as long as it's between somewhere 12 and 20, they're normal. For the test, you can be off by 4 breaths in either direction and still be accurate. So if the evaluator got 16 and you got 12, 13, 14, 15, 16, 17, 18, 19, or 20. I'm sorry. Respirations is 2 breaths in either direction, not 4. Pulse is 4. Respirations is 2. So if you got 14, 15, 16, 17, or 18, you're still considered accurate. So way huge margin of error here. It's not about accuracy. The test is not testing your accuracy. They don't care about accuracy. What they care about is technique. And part of the technique is this. Do not tell the patient you're counting their respirations. Because when you tell somebody you're counting their breathing, it makes them aware of their breathing, and they generally will breathe different. They'll either stop breathing or they'll breathe too fast. Either way, we're not getting something accurate. So for this skill, I'm actually going to say I'm taking your vital signs. I'm not telling them I'm counting their respirations. I'm just telling them I'll take your vital signs. Okay. In and out is counted as 1 full cycle. So it doesn't matter whether you start counting on the inhale, the middle, or the exhale. It doesn't matter. As long as one of those happened, it is a cycle. It is counted. Okay? Good? Questions? Okay. So how long do you count? As long as care plan tells you to. Just like pulse, you can shorten this to 15 seconds and multiply that by 4, as long as your care plan doesn't say otherwise. But this care plan does. This care plan says to count for 1 full 1 full minute. So how long are we counting? 1 full minute. Don't take any shortcuts. That is the reason this skill is failed, is because of timing shortcuts. So yeah, we already know this. Normal values are between 12 and 20, and just like pulse, we're going to tell the evaluator when we start counting and tell the evaluator when we stop counting. They're going to count at the same time because we counted something we have to document. So on page 48, I have a whole lesson here on documentation principles. So the big thing to remember about documentation, as CNAs, you are rarely going to document in words. CNAs are usually not allowed to use words in documentation. You stick to numbers, pulse, respirations, blood pressure, the amount of urine that you emptied out of the bag, the amount of cc's that the patient took in at lunch in liquid form. We stick to numbers usually. Now, if you're working in a setting that requires that you document in words, they're going to teach you the principles you need to know. But generally speaking, this is called the ABCs of documentation. Generally speaking, your documentation needs to be accurate. It needs to be brief, but it needs to be complete. You want to limit the use of I statements. So you don't want to say something like, I counted the patient's respirations. You just want to say respirations 20. Keep you out of it. The focus should never be on you. Who should it be on? The patient. You also don't want to be rambling. Brief is good. Brief is good. But be complete. Never document something you did not do. So first of all, that's lying, right? Don't document that you did something if you didn't do it. But you can't document for other people either. So don't document something you did not do. So if you tell me you're going off shift, I'm coming on, you say, oh, I forgot to document patient's respirations were 20. Can you document it for me? My answer is no, I'm sorry. You need to document what you did. Don't document for other people. Okay? If you make a mistake when you're documenting, we never erase, we never use white out, we never destroy documentation. They are legal files. Can you imagine going down to the local courthouse and just grabbing some legal files and shredding them? You can't do that. They're legal files. We can't destroy them. Well, everything in a medical record is a legal document. You can't just destroy it. So if you make a mistake, we can't cover it up. We can't obscure it. You can't use a Sharpie. You simply write one line, one straight line through the mistake. And above it, you're going to write error in your initials. So we can read what the mistake was. So we're not hiding anything. Hiding means a secret. A secret is never good in a courtroom. So one line, we can see what's underneath it, but it doesn't apply to this patient. Maybe it was a wrong chart, wrong patient, could be. Maybe you wrote a number you weren't supposed to write. You were supposed to write 20 and you wrote 12 instead. Doesn't matter. One line, error, and your initials. Okay? Good? Okay. So there is something about respirations, though, that I have to show you for you to truly understand here. I need a volunteer. Somebody come lay down in the bed for me. Anybody? Oops, forgot. Okay, when we are taking respirations on a patient, turn this around here. When we're taking respirations on a patient, we don't want to tell them that we're counting their respirations. We've already talked about that, but there's another component to this that is equally as important. I have to have this patient comfortable. If the patient is not comfortable, I'm not going to get an accurate reading. All right. So time out 1 second. I need to make her comfortable because she's not. Lift your head up for me, please. Okay. See if that's any better. Better? Okay. So time back in.
You don't have to do that for the test. I'm just doing that for her because we're going to be here a minute. But I have to make the patient emotionally comfortable. Okay. If I'm just standing here at the bedside, how comfortable are you? Not. No. People get freaked out, weirded out if somebody is standing over them, staring at them, and not touching them. I mean, that's the stuff that horror movies are made out of. We don't want to do that to this patient. If we do that, that's going to make them anxious, which will speed up their breathing. So when I'm going to count respirations, I want this patient to think that I'm counting her pulse. That puts her at ease. So instead of standing there like this, which is really nerve-wracking, I'm going to do this. Much more comfortable, isn't it? Weird. This skill is all about psychology, guys. All about psychology. But there's something that we can do on the test to make this a little bit easier for us and the evaluators as well. So you can and should use this for the test. If you look at her tummy going up and down, you guys over there might be able to see it, but it's really kind of hard to pick up because it's a dark outfit that she's got on and you're way far away. Where do we want those evaluators when we're taking the test? Right over us or against the wall? Yeah, we want them far away. Well, if they're far away, it's going to be hard to see their breathing. You can kind of see it going up and down. You guys at home might be able to see it go up and down, but it's kind of hard. There's something you can do to make this easier. I just need to lay that there for a second. Wow, now you can see it, can't you? Now it's like visible. We want those evaluators to be able to count respirations across the room. If you put an alcohol pad on their tummy, it makes the respirations more visible. It did not affect her breathing at all. I did not change her breathing. What I did is use psychology to make it more visible to you because our eye is drawn to movement when it's a contrasting color. This is what kept us safe in caveman cyber-tooth tiger days, right? We'd see flashes out of the corner of our eye if it was movement and it was not a color that blended in. It was probably a danger. So we're drawn to that. And that's what I'm going to use here. So for this skill, we're going to do our opening, wash our hands. We're going to put an alcohol pad on the tummy. We're going to hold the wrist and we're going to look at the clock and pick a starting point. We're going to say start out loud. We're going to count the respirations. Remember, in and out is 1. Until the second hand gets all the way back around to that point, we'll say stop. We're going to do our closing, wash our hands, and document. Okay? So I'm going to do this whole skill from beginning to end, but I will simulate hand washing for the sake of time. Here we go. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I need to take your vital signs. Is that okay? I'm going to close your curtain. Let me go wash my hands, and I'll be right back. I have clean hands. It's all you have to do for the test. After the first skill, they're going to tell you you can simulate hand washing. So it's just a matter of saying, I have washed my hands now. Okay. All right, Ms. Jones, I'm going to do all the work here. I'll just need you to rest quietly. This does take a minute. I will need you to remain quiet until I'm done, okay? All right, let me hold your wrist. Can everybody see? Those of you out there, I want you to count the respirations while I do. You are my evaluators. Those of you at home, you should be able to play along as well. So here we go. Ready, set, start. Stop. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Would you like a magazine before I go? Environment is clean. Bed is in the low position. Here's your call light. If you need anything at all, just hit that red button and I'll be right in. Open the curtain. I'm going to go throw my alcohol pad away. Wash my hands. And then after washing my hands, I'm going to get the documentation sheet that the evaluator provided for me. This is the one, this has everything on it for you guys to practice with. And I'm going to document my reading. After that, I'm going to read the care plan one more time to make sure I did everything okay, and then tell the evaluator my skill is done. What did you guys get? 19? Did you get 17, 18, 19, 20, or 21? You're good. I got 19. Okay. Questions? Thank you. All right. In your skills book on page 49, there is a lesson on military time. If you're not familiar with military time, I would do this lesson because we do use it in clinical settings. We do use military time in clinical settings, so you do want to be somewhat familiar with this. All right, we are going to switch gears now. Take one and pass it off. And can you pass that one back, please? Okay, so we're going to talk about test registration instructions now. This is super important because left on your own, you probably will make a mistake registering for the state exam. It's a little bit more of a complex process than you would think. So I have test registration instructions on my website. If you go to foryourcna.com, look under the testing menu. It's right here, test registration instructions. I have a video where I actually do a registration on the screen, and then I have slide presentation that's step by step. So the video, watch a video to get an overview, and then go through the slides. That way you don't have to keep pausing the video. So the first thing that you see is this page. This is on the front of the packet that I gave you. This page tells you the 4 steps of test registration. First is we need a background check. Some of you already work in healthcare and you have a background check. That's awesome. You don't have to go get it from anywhere. If it's in the clearinghouse, Prometric will find it. But if you don't have a healthcare specific level 2 photo enabled background check in the last 5 years, you got to go get one. Got to go get one. So we're going to go through that process first. You got to get the background check done before you register. So we're going to talk about the background check really quickly. This is the site that we go to register for the state exam, or you can send in the paper application I just gave you. Either way is fine. But this website, if you go on to prometric.com/nurseaid/FL, way down under candidate resources, you will see a list of vendors for the background check. Now, for you guys in my class, I gave you the one that's local to us, and that's Deontis. You're going to want to go back and watch this part of the presentation for this, okay? You're going to want to go back and review this. Trust me, you will. So this is at 3 hours and 50 minutes in. Okay, so go to class 4, 3 hours and 50 minutes in to get to this part that I'm going to tell you about. So when you go to deontis.com, you're going to have to create an account. Let me go back here. There's 2 places you can click on to create an account. The first is up here. It says create account. That's pretty simple. But we also have down here on the first page, you have register. Either one of those will get you to this page to create your account. When you create an account, you have to have one of those super secret passwords with letters and numbers and symbols and all of that. And then they're going to send you an email that you will have to verify. So make sure you have access to the email address that you use for this. Once you create your account, this is where it gets really confusing with Deontis. And you have to register online. You can walk in. They use the UPS store on Barclay. You can walk in for a background check, but they're going to charge you $20 more. I don't know about you, but $20 is a lot of money. So if you just go online and register, you'll save yourself money. So if you go, after creating an account, you want to go to Florida Services, and you need to have this ORI code. Okay, it's right here in the shaded square, EDOH 0380Z. So it's right here in the gray square. Yep, right there. So you'll need that code, because when you click on Florida Services, this is the page you're going to see, and you need that code. You're going to put it in there. When you put the code in, then it's going to take you to this, verify. We want to make sure it says CNA by exam. That way you didn't have any typos in that code. If it says, then you're going to hit next, and it's going to ask the reason for the request. This is what really messes everybody up. You want to choose other employment and licensing. Remember, licensing is what we're trying to get to. And then once you do that, there's going to be an OCA. Just leave that blank. We don't fill that in. Okay. You see why I say you probably want to go back and review this. 3 hours and 50 minutes in. Okay, then we get to the normal stuff. Your name, your address, your phone number, all of that stuff. And once you fill that in, it's going to ask, okay, we've got your information now. We know who to send it to. That's great. Where do you want to go to get your fingerprints done? So you'll put your zip code in, and it'll bring up a list. Of course, our closest one is the UPS store on Barclay. So we're going to click on that. And it's going to let us set up an appointment. You can do same-day appointments in most cases. So we're going to click on that. It'll ask us what time we want to choose. Once we have our appointment set up, it's going to send us to the payment screen. Because we're doing all of this online and not there taking up their time at the UPS store, they're charging us less. Okay. So this whole thing is going to cost right now $76.68. Subject to inflation. Please remember that. Don't yell at me if the price went up. I don't control this. But I just did this last month to verify this. So you'll put your credit card information in, and then you'll go to that appointment. When you go to the appointment, they're going to take a photo, your fingerprints, and a signature. And they're going to leave. You don't have to take anything anywhere. You're not going to get a copy. You just go to the appointment. That's it. That code tells them where to send that background check. And it's important that you don't have access to that background check, because if you have access, you can use Photoshop to change it. So this is a chain of custody thing. They take your fingerprints and your photo, and then they send it off. You have no control over that. The code tells them where to send it. That's the important part. Now, after you do your background check, wait about 24 hours, and then we're going to go to prometric.com/nurseaid/FL to register for the test. When we do that, the paper application I printed off, that's what you have in front of you, but you can also register online. This is that column 2, gives you that website. So you can register either way. The online application is exactly what I gave you, but online. But we're going to fill this out, some of it together, so that I can make sure you know the important parts so we don't mess this up. Okay. Prometric's contact information is on the side of the screen. Please make note of this. If you have a problem with your application, you need to contact them, not me. So their email address here, their phone number, they're not always easy to get a hold of. Be persistent. That's all I'm going to say on that matter. Be persistent. But when you go under application process, you got the online and the paper. The paper is the one that you have in front of you. So let's talk about the paper application. This is what it looks like. It's in the packet that you have, along with other information we're going to go through in a minute. But you can see on page, is it 5? I'm sorry. On the back of the second page is the beginning of the application. So when you fill this out, you're going to, it's going to say stop, make sure that you have 2 forms of ID with the name that you're putting on this registration so we can verify you. It's going to ask if you need ADA accommodations, like a seeing eye dog, a sign language interpreter, something like that. And then we get down to the demographic stuff, which you can fill in on your own. We're not going to take time in class to do that. So fill out all your demographic. But then we get to this part here where it says criminal, Medicaid, Medicare, fraud questions. So I want to talk to you guys. This is something we are going to fill out in class together. Anybody that has a felony in your background, if you have a felony in your background, you need to see me after class to help you with this. If you have no felonies in your background, for number 1, I want you to check no. Skip A, B, C, D, and E. Do not put anything in those boxes. Just box 1. Go down to box 2 and check no. Skip the A's and B's. Now, for questions 3, 4, and 5, I need to explain to you what these questions are all about. If you have worked for a medical provider who committed Medicare and Medicaid fraud, let's say that you were a medical assistant in a pain management clinic that bilked Medicare out of millions. During their prosecution of that clinic, you, as an employee who knows how to defraud Medicare, would be put on a list that says you cannot work in healthcare anymore. You guys understand that? That's what questions 3, 4, and 5 are asking. Are you on a list? Were you part of a prosecution against Medicare or Medicaid fraud? This is not as a user of Medicaid. This is as a provider. If the answer is no, check no for 3, 4, and 5. Skip all the A's and B's. Now we're going to go down to disciplinary history. If you were a healthcare provider in Florida or any other state, any healthcare provider, a CNA, a physical therapy assistant, an occupational therapist, a dietitian, anybody that worked in healthcare, and you were certified or licensed, and disciplinary action was taken against you. So if you were a CNA and knocked around some old people in Indiana and had your license suspended, and then you came to Florida and thought you'd do it here, they want you to declare that. So if you've never been a healthcare professional in any state, the answer is going to be no all the way down. If you have been a healthcare professional, if you've been licensed in something, you need to read those and answer them. Yep.
PCAs aren't licensed, right?
They're not licensed. No. Did you have any disciplinary action taken?
I don't think so.
Okay. Then you're fine. It's still no. All right. So now we're down to criminal history. This one's easy, guys. Yes or no? Pick one. Either you've had one or you don't. If the answer is maybe, it's yes. If you're not sure, then it's probably yes. Second question there is a expunged record or sealed record. Third one is a juvie record. And then we get to page 4 where it asks about health history. I can't help you with anything on page 4. You're on your own. So you answer those questions. You do your social security number at the bottom. Let's go back to, or let's go to the next one. I want to bring your attention back to this page and the front. Do you see where it says important at the bottom? I want you to put a star next to that, highlight it, do whatever you need to do where it says important, because it is important. This is the one place that most students mess up their application, and it can delay your testing by up to 6 months. So when I say important, what do I mean? I think it's so important that I actually did it for you. On this page, page 6 of the application, you will see that I checked off E3 Challenger. Keep going. Yep. So you'll see E3 Challenger, I've already checked off. Do you guys see that under certification route? E3 Challenger, already checked off. If you do the online registration, make sure that you choose E3 Challenger. Don't choose anything else, or you won't be able to test. I know you're sitting in a classroom. This is not an approved 120-hour program. I have no program code to give you because we don't go out and do live clinicals. Okay? If I did, this course would be $1,200. You guys don't have $1,200. You're getting the exact same education at a quarter of the price. All right. Below that, it's asking for training information. I've already put an X through that for you. We're not going to fill that out because we only have to fill that out if we check E1 or E2. What did we check? E3. Below that, we are going to test a regional test site. So check the box that says regional. Check the box that says regional under test site information. Check the second box, regional. These 2 pages, so if you open, these 2 pages are all the testing sites in Florida. All the testing sites in Florida. The one that we are probably going to, and if you go down to the bottom of the first page, you'll see Central Florida. I've divided them up by regions for you. The one that we are probably going to be using is the very last one on that first page, Agilus International. That is our closest testing center. But you can look at the others that are there. And if you're sending in the paper application, you need to put that test site code. So next to Agilus, you saw CNA TAMAIR. That's the code you would put in there. TAMAIR. Do you see where you're probably going to have to bookmark this and go back to it? All right. After that, and we already did the test center list. Yes, we've already done that. So after that, after you do the test center list, we're going to tell them what exam we want to take. So we want to take the first time CNA testing exam that has the written and the clinical. If you fail one part, if you fail the written and you only have to retake the written, well, there's an option for that. If you fail the skills and have to retake just the skills, there's an option for that. But we want to take both sections. So we are going to check off the first option there where it says clinical skills and written, both in English. Now, the second one there says oral. If you want the computer to read the written test questions to you, if English is not your first language, or if you have a learning disability, that might be helpful. You can check off the second option. The written test can also be given in Spanish as well. That's an option. But you're learning in English, chances are you're probably going to want to test in English. And then, so first-time testers, the first option is generally the one that we use. Okay. So the cost is $155 for the exam. And this last page is your affidavit. But the first section there I want to talk about really quickly. The first section says that, yes, you have been provided a copy of the FDLE privacy policy. That's the very last page here. I actually gave you both of the papers that you're checking a box that says, yes, I received. You can check that box because you have those papers. If you're doing it online, there's an actual link that you can click on to open it up to get those papers. But yes, you have them. Then you're just going to simply sign and date. Okay. Pay attention to this at the bottom of your application. It says if you do not receive your authorization to test within 10 to 14 business days from the time that you submit, that you need to contact Prometric. 10 to 14 business days. If you have to call Prometric, you are going to quote that to them. My application, my contract with you states that you should provide an authorization to test within 10 to 14 business days. If it has been 14 business days and you do not have your authorization to test and you call them, do not hang up until you get an answer from somebody about this. Because what happens is when you call, you're not getting somebody that understands this. You're getting a minimum wage worker that is there to get you off the phone. And they'll tell you, oh, it can take up to 180 days to clear you for testing. No. What does your contract say? So you ask for a supervisor. Got it? It's been happening to about one student every class. So you need to know what to say to get to the right people. Don't call me in a panic going, oh my gosh, they told me it would be 180 days. What does your contract say? 10 to 14 business days.
I have a question. I don't have to do the background because I'm already in the house bill.
Okay, so just apply.
If I do it online, how long does that take?
So if you apply, fill out the registration online using everything that I just gave you, you should be testing about roughly a week or two after graduation. Yeah, the processing time is taking about 3 to 4 weeks, which puts you at a week or two after graduation. That's why we do it at the midway point. Okay? You want to be after graduation, but you don't want to be too far after graduation. Okay. So remember that the contact information is here for Prometric. Once you submit your application, you're 1 to 3 days later, you're going to get an email that says you submitted. Look to make sure it says the application status is complete. If it says incomplete, you're going to need to know why. Maybe your payment didn't go through. Maybe they couldn't find your background check. You need to find out why. Once you get that where it says complete, then about 7 to 10 days later, you're going to get your test date. Okay, good. All right. It's the weekend. Homework, 2 chapters. Chapters 5 and 6. 5 is on dementia. Pay attention. You'll have a lot of dementia patients as you go through your career. It's important to know what it is and how to work with it. And chapter 6 is skills. I'm not worried about skills. We're covering those in class. Read the paragraphs in between the skills, though. Okay. All right. Replays. I just got a hold of my VA, Caitlin. She is awesome. And I asked her to resend out your after class wrap-up emails for classes 2 and 3. She said she sent them. So make sure you get them. If you did not get them, send me an email and let me know. Remember, my email is up here at the top of your syllabus. Just send me an email. Let me know that you're not getting your after class emails so I can troubleshoot it a little bit more effectively. But she set it up. So hopefully everything should work well from here on out. Okay? All right. Congratulations. Another class down. You are officially at the halfway point. Goes quick. I will see you on Monday. Have a great weekend. Try to have a little fun. It is Mother's Day. Happy Mother's Day to all that apply. Nope, Sunday. Yeah, don't panic yet. You got time for flowers. All right, to all of my virtual people, thank you so much for hanging in there. And we will see you on Monday at 9 a.m. Happy caregiving. Bye.